that I can invite Suri then.
Yeah, sure.
If they join later, I can invite them, no problem.
Yeah.
We are live on YouTube now.
No, yeah. Four minutes to go. Krishna wants to check your screen.
One thing, can I check my screen? I will. I know. Can I check my screen?
Yes.
Already checked?
Go ahead before Dr. Mohanty starts. Yeah.
Is it coming? Can you see the screen?
Yeah. Yes, sir. We can see this.
Okay. Let me now get back to. Now, if I have to go to my video, what do I do now?
Krishna, I'm not able to see your
Go
screen.
to the slide where you have the video.
No, the video is separate.
So maybe you can put it in one of the slides and then.
Okay.
So you still have some time. Maybe you
But
can.
directly screen share can be done.
Is it on the desktop? You can share it there.
Yeah, it's on the desktop. So how do I reach there?
So close the presentation. You can minimize your presentation so that desktop will be seen. Then you click on the video. Minimize this presentation. Yeah.
Yeah. So now.
It is not minimized still.
No, sir. You'll have to minimize the presentation, and then on the desktop, wherever your video is, you click on that.
So if this is a presentation, I minimize it now.
Yeah.
Now, what next?
No, it's not minimized.
It's not minimized.
Come down, Manoj.
Yeah.
There is a minimization cursor below. Use that.
One minute to go.
Okay, I'll put it in one of my slides then.
Yeah. You put it in the slides.
One of the slides.
Let me start sharing the screen. Am I okay? Screen is visible?
Not yet.
Not yet, sir.
Share screen ले लो session button अब तो हैंग आधा पड़े
Is it seen? Submit?
No, sir. Not yet.
I'll stop share and do it again.
Presentation
Okay.
and it will automatically change to that, and you need to click on that when you need to advance, because spacebar doesn't work because you're in zoom in that point, at that point. When you want to move to the next slide, you just click on it.
Fan on this and
Space works from second slide only.
Am I okay?
So the screen is not visible as yet.
Then again I'll do. 1 second. Give me some.
So I think it's taking a bit of a time. So when you just on it, just wait for some time. Yeah.
Just tell me when you see.
Yes, sir.
Okay.
Not yet, sir. Just it's visible now, sir.
Visible now?
Yes, sir. Visible now.
Full screen?
Yes, sir. Yes, sir.
Okay, so I'll start.
Yes, please.
Okay. Good evening, dear friends. Greetings from Indian Arthroplasty Association and welcome to the 15th 360-degree Indian Arthroplasty Association webinar series. Now, I am Subhranshu Mohanty, the president of the Indian Arthroplasty Association at present. We started this association way back in 1995 and completed 25 years in 2020. So we celebrated our silver jubilee year under the shadow of the pandemic. And again, along with the pandemic, we started with this webinar. And initially, we used to do these webinars weekly. Now we are doing it on monthly basis. You will get more information about the Indian Arthroplasty Association in our website, that is www.indianarthroplastyassociation.com. And if you have any suggestions and any comments, and you can email us at indianarthroplasty@gmail.com or in my personal email ID, dr.ssmohanty@hotmail.com. Now we have, made groups, all life members. Those who are listening, if you are a life member, then please see that you are in one of these groups. If you are not, then please message me my number so that I can include you in one of these groups. We have live clinical case discussions which are going on in this group, and you will get all the information about the activities of Indian Arthroplasty Association. Those who are watching here on the YouTube channel, and if you're not members of Indian Arthroplasty Association, I request you to go to our website and apply online for our live membership. Today, the webinar series number 15 is devoted to reconstruction strategies in revision total knee replacement. And our convener is none other than Dr. Anup Jurani, who is the Director of Orthopedics at Fortis Escorts Hospital in Jaipur. And we hold these webinars every third Tuesday of every month in the evening time. And it's, lively, you can watch in the YouTube and Facebook channels. And we have three stalwarts in the field of, revision knee arthroplasty around the world as our guest speakers today. Dr. Kelly Vince is a consultant orthopedic surgeon, senior medical officer at Northland District Health Board at Whangarei, Northland, New Zealand. Earlier, we know Kelly was in Los Angeles, California. He received his medical degree from McGill University Faculty of Medicine and has been in practice for more than 25 to 30 years. And he has extensive publications, and all of us heard him all over the world in every arthroplasty meeting where Kelly is present. And he has been extremely popular and extremely good orator. Our next is Mr. Ridian Morgan Jones, who is a consultant orthopedic surgeon and especially knee, specializing in knee at Troyan Clinic Orthopedic and Spinal Hospital in London. He provides national and international service for the management of infected knee, revisions, total knee replacements, chronic osteomyelitis, dominance, and lower limb reconstruction. He is an expert in the revision arthroscopy as well as revision anterocruciate ligament surgeries. Currently, he is an elected British Orthopedic Association trustee and serves on the several national committees working on infection and revision knee services. He is NHS based in the University Hospital at Cardiff. Welcome, Ridian, to this webinar. And my friend Dr. Amar Ranabat is our next, invited guest speaker today. Everybody knows Amar. He's attending orthopedic surgeon at Hospital for Special Surgery, New York. He's a professor of clinical orthopedic surgery at Weill Cornell Medical College and attending orthopedic surgeon at New York Presbyterian Hospital. And as you know, every year we have Ranawat Orthopedic Conference, and he is the present course chairman for this Ranawat Orthopedic Conference. On a lighter note, when there was some scientific meetings, when a guest speaker was told that you know what are the rules of this meeting, he told, I know the first rule is that every 15 minutes you have to utter the name Ranawat, and that is how now the entire Indian arthroplasty surgeons, they are devoted and they're committed to Ranawat, and we are all part of the extended family of Ranawat in Indian arthroplasty scenario. Welcome, Amar, to this webinar. Now we have host of our own stalwarts and speakers amongst Dr. P. Surya Narayan from Chennai, Dr. Krishna Kiran from Hyderabad, Dr. Manoj Wadhwa from Delhi, and Dr. Ashok Rajgopal from Delhi, Dr. N. Rajkumar from Coimbatore, Dr. Mahesh Kulkarni from Pune, and Dr. Nilen Shah from Mumbai. So we are looking forward to an excellent academic extravaganza today. Now, without any much ado, I hand over the proceedings to our convener today, Dr. Anup Jurani. Anup, over to you, please.
Thank you, Dr. Mohanty. And the whole idea of holding this webinar was to take a stepwise approach of reconstructing a revision TK, right from exposure to how to balance the knee, then to fixation techniques, stems, augments, sleeves, and go down to the deepest point and pearls of all these various facets of revision TK. Unfortunately, as we speak now, Kelly, Vince, and Ridian haven't joined. They had the first two talks. We had arranged it so that they can, they can come at their own time, but they haven't as of now. So we'll go with Suri's talk, and as they join, maybe we can accommodate them. So Suri, over to you for how to expose a revision knee, especially a stiff one, which doesn't move beyond 30 or 40 degrees.
Is the screen visible? I'm sorry.
Yes,
Yes.
please.
Thank you, Anup, Dr. Mohanty, Indian Arthroplasty Association, during your Silver Jubilee year. I think indeed a great honor to be called in to make some marked remarks and presentations. Dr. Anup had mentioned to put in more of specific bullets that maybe take home with regard to this, and I've done exactly the way he has requested me to do it. Exposure, of course, forms the primary approach. If you are exposed, it's all about exposure in the revision surgeries. You have good exposure, then you follow the principles, your results are pretty much predictably good. There are three major objectives. When you say what is an optimal exposure, there are three major objectives. One, I think we have to have exposure enough to be able to identify and visualize the positioning landmarks, because we depend a lot upon the anatomical structural landmarks for our component positioning and aligning the components completely. To achieve this, I think it's also necessary to get the lateral corner of the knee, especially on the tibial side, the lateral and the posterolateral corner out of the way, so that if patella comes out of the way, you have a good clarity on the exposure. Tibia needs to sublux itself completely anteriorly so that the extraction implantation of the tibial components, more commonly the stemmed ones, is facilitated and it becomes much easier for us. So these are the primary objectives in whatever we do to expose this. The problem often we find the difficulty mainly is because of extensive fibrosis that can occur because of those components, sometimes because the mobility has been very poor and the people have not been moving. So the obliteration of all the gutters makes the patella mobility very poor. There is a patella baja at times because of the quads contracture, intra-articular fibrosis. All this makes the patella mobility very poor, and we find that the lateral translation or the evolution of the patella becomes extremely difficult. In addition, if we forcibly do something to mobilize and try to get the knee into a flexion position, the osteopenia and the distal peeling and avulsion could be a potential possibility, and this needs to be avoided at any point. Pay attention to all the previous scars whenever you look at it. When often we may find multiple scars, you need to identify which is the safest one. Always realize that dominant blood circulation comes from the medial side. So the Doppler assessment, if feasible, like the plastic surgeons do, sometimes is very useful to know where the perforators are, and maybe have a chat with them and identify the most appropriate scar. As a rule, the most lateral incision would probably be safe enough in these cases, but it could vary at times, and one should be careful about this. In extreme cases, when they've undergone multiple procedures, open injuries, and you're revising these things, or even primarily opting to do a knee replacement in this, work in tandem with the plastic surgeons, mark the incisions primarily with them, so that in terms of any trade-off, they can walk in and give you a flap cover or a tissue cover as the situation may demand. Like I always say, once you open the skin, remember there are a lot of interfacial adhesions always in all these cases. And if you have a composite thick layer which is stuck to each other, unlike the normal situation where you can move the skin and the subcutaneous tissue over the deep fascia, it becomes very difficult to evert or laterally translate the tissues or the flap completely. So I like to say, soften the flaps first. In this, it is very important that when you do that, you probably try to recreate the planes. It will be adherent. It may take a little, about a few minutes, 4 to 5 minutes, but separate out the subcutaneous and the deeper layers, deeper to the gallia of the tissue or the deep fascia, so that the viability of the flap is not compromised. This restores the interplanar glide, and it becomes much easier for us to sort of mobilize and move the patella with the lateral tissue medially or laterally as the situation at that time in the surgery would demand. And you would find it pretty much useful to proceed with this. Some of the primary extensile steps is, of course, the excision of the scar, which you should continue. And then in all the planes, take out both of the medial gutters and the lateral cutters. If the exposure is very constricted, you could extend the quadriceps incision more proximally. That also gives you additional room. As you sort of excise the lateral tissue, you will find that the patella comes into view, and you are able to gradually pull the patella out, and you expand medial-laterally the whole area that is available to you. Avoid any forcible eversion at the first instance before removing these sort of fibrous tissues, because if you don't free the gutters, they really don't become very easy to mobilize. And a patellar sort of a tendon avulsion is often catastrophic and should be avoided at any point in time. Second area where you need to focus is the lateral side exposure. Medial side is never an issue. You are able to get enough, but it's the lateral and the posterolateral corner of the tibia. To sublux the tibia out, you will need to work on the soft tissues. So what I say, you need to excise the root or the scar tissue at the root of the patellar tendon. Take it out at the top, like you see in the picture to the left. That area, you could probably recess it from the tibia for about 20%. Once you have done that, then attack the infrapatellar fat pad, which has scarred. Take out the retropatellar tendon scarring. As you do that, again, this significantly aids you and gives you an access to work on the lateral margin of the tibial residual bone on the rim and the periphery, and that will make it much easier to get more exposure. When all this fails and it does not adequately enough and you're still tight, you're not able to flex the knee beyond 50, 60, I think it's important to consider the tibial rectus snip. This is one additional proximal extensile maneuver which is used most commonly in 9 out of 10 situations. You will escape with just this much or nothing at all. So this is how you do it. This is the quadriceps tendon defined. It is not necessary that it needs to be cut completely. You start with the rectus. Once you release the rectus and see how the patella mobilizes and translates. If it's not, you can do the distal vastus intermedius tendon, which can be partially released and gradually extended as much as the situation may demand. And once you do this, you will find you are able to take this out and open up the flap pretty easily, where exposure is elegantly available for you. This is something which has been very commonly used by most surgeons. Morbidity is very minimal. It doesn't alter your post-op approaches, widely adopted, and it's just an easy modification of the regular arthrotomy. All these approach modifications which have been discussed in the literature are more probably historical today. We rarely use it, but there are some diehards. Once in a way, you might use it. But the biggest disadvantage of distalizing or taking a flap down of the patella and the quadriceps tendon is a significant delay in the rehabilitation and a lag that takes months to recover. And the range of motion at the end of it could still be limited in these cases. Another point, like I mentioned at the beginning, was get the tibia anterior completely in front of it. After all these exposures, usually you must be able to do it once you take off the femoral component. Sometimes you may need to dissect the posterior capsula from the posterior margin of the tibia or the femur. Once you do this, the whole structure comes entirely front. As much as possible, the component should come out in a vertical straight manner. If you toggle and angulate, there is a potential possibility may further damage the bone. So avoid it at all points by getting an appropriate exposure. The biggest impediment for this would be the posterolateral corner. And you have to make sure that you are bringing it out completely in front. So to avoid the tibial tubercle injury or avulsion in stiff and tight knee situations, we systematically go pointwise with all the previous steps. We should be able to get good exposure. Avoid eversion, laterally sublux the patella, do a generous quadricep snip. You don't have to hesitate because it doesn't alter the outcomes. Composite sleeve elevation on the medial side. A smooth pin transfixation has been talked about, but personally, I have not found it extremely useful at all, basically because the bone tissue is very soft and it really hardly protects this. So if you choose to do it, certainly fine, but be wary that it may not give you a total protection. There is the other possibility which is possible in these difficult situations is a typical tubercle osteotomy. This is a distal extension of procedure. Great exposure which you get with this. Eversion becomes very easy. And one big advantage which I personally was thinking was the minimal dissection into the quadriceps muscular apparatus. You keep it pristine. And some of the proximalization of the whole apparatus in terms of significant patella baja is possible to some extent. The scarring subsequently becomes much less. And access to canal in term to remove a well-fixed tibial stem, if it's non-stemented, would be another collateral advantage you may face with this. Where probably it is, I think there has always been a discussion about whether or not should you not. But I think it's one option one could consider and keep it in mind, which I thought I can discuss. It's most useful in very difficult exposures, stiff knees, very fixed deformities, and revisions in some situations, and occasionally in a scarred post-trauma situation. There has been a flip-flop also in the literature, tibial tubercle osteotomy, raising a lot of concerns in the earlier times with regard to the mobilization, healing, tubercle fracture, necrosis, everything. On the other side, we had Michael Reyes and other colleagues who talked about re-osteotomy in the difficult re-revisions, and they found extremely good results. So you have, I think, a database on both sides of the frontiers, whether to do or not to do. But I think it is something which is worthwhile. I'll just go straight to a small video. In this case, this is a 4-minute video on tibial tubercle osteotomy. This is a person who had a primary, was a stiff knee with infected, which was implants were removed. So here we are doing with a tibial tubercle osteotomy. He had a flexion to about 40-45 degrees. Standard medial arthrotomy, there is no change in the initial times. You make a little longer distal extent, at least about 8 centimeters to 9 centimeters of the limb. Mobilize the medial flap. Don't do anything on the lateral side. You have marked a 7 millimeter point, which is about 1 centimeter to 1.5 centimeters behind the central ridge of the patella, tibial ridge. You mark it. You can take a scale, mobilize, and take a sort of a step wedge, 7 to 8 centimeters long, 1.5 centimeters wide, and a step cut as a distal tip. There are certain modifications described. It may be a straight down, a step cut, a bevel cut. I think there are various modifications that's available. Once you have defined the marking, just cut through the periosteum right onto the bone so that you have defined the line of resection. I use a small blade which we used to use in the earlier times for the bone patella bone ACL reconstructions. So you do a minimal medial dissection like we normally do in these cases, but no lateral dissection whatsoever. Go straight down, but you angulate the osteotomy blade more towards the opposite side as superficial, not very deep. Don't enter the medullary canal if possible. Multiple small osteotomes help us to complete the osteotomy on the lateral side. If it is very tight, probably you can drill it, or sometimes just give a little gentle nudge and get onto the opposite side at 2 spots or 3 spots. So that defines the line of osteotomy on the far cortex without any soft exposure. You then evert the whole osteotomy completely, and then you put in your retractors. So this is the eversion of the osteotomy segment. You see that we have not transgressed the intramedullary canal in this case. Now you have the freedom to release all the lateral fibrosis as deep to the flap, right, as a single composite tissue. And then you start mobilizing. Here you then slowly start finding that you're now able to slowly start flexing the knee. You take out. This is the corner where you excise all the tissue. The posterolateral corner tissue is completely removed. You prepare your tibia, you prepare your femur, do the way the subsequent experts and stalwarts are going to talk about. And once you have completed the whole procedure, then you trial how well the osteotomy fits. Usually, if your joint height, everything is good and right, it just falls in straight, completely down. You put it, position it completely down. You can hold it with one bone holding forceps, temporarily sort of stabilize it with two Kirshner wires in different axes. If there is a stem, I think you sort of do a miscellaneous technique control. 2-1 proximal suture, get it through the range of motion, and then you can complete the fixation. 3.5 millimeter full threaded cortical screws is what I found, bicortical, 2 or 3. Don't use a 4.5, 3.5 is a good one trade-off. And the lower screw should be not below at least 1.5 centimeters from the tip, so that you don't sort of crack the distal tibial stem. So you get the 3 fixations, they align themselves completely well, and then you see that the range of motion can be completely assessed. This is the post-operative pictures at 6 weeks. You find that there's a gap in that osteotomy, but that just settles down, and this is the function at the end of 6 weeks. In the closure, like I said, there are 3 possibilities you may find in this case. We saw this, how it closes. You can either have this sticking out on the distal side, or sometimes there is a proximalization as you see on this side. This is something that sort of a self-adjustment that occurs when you get the range with the patella holder through the range of motion to about 90, you realize if it has to go proximally, it will go proximally on its own and fix it in that position and get the screws down inside. That is a stable way to do it. That was just a video to show how you obliquate the screws on the coronal plane so that it sort of misses the intramedullary stem and you stay within the cortex on both the sides, medially and laterally in these cases. So the concerns usually have been the local problems, osteotomy, union, rehabilitation, fixation modes. But basically, if you do it in the right way and fix it at 90 and do not change your post-op rehab, it works very well. But certainly it is not advisable. You need to give a word of caution. Revision in cavitary defects, poor bone stocks, very thin cortices. I don't think this should ever be done. You should have robust bone available enough for you to detach and reattach at the same time. Extended dissection time may be in the initial cases since we are forcible, but probably I won't say it will take more than about 10 minutes in addition besides this. Our experience, I think this was compiled sometime in 2015, was about 22 to 23 cases we had done. We had a good rehabilitation was immediate in 20, delay till suture removal was about 3 cases for reasons of soft tissue healing. Fixation in 2 to 3 screws in 21 out of the 23, the other 2 we use some cerclage wires. If you're using a cerclage wire, let the wire go behind the stem before you fix the stem. Quadriceps function, there was a early lag in 13, but full resolution was seen in about 6 months. I thank you for your attention.
Excellent talk, Suri, as usual, very clear and concise. Let's have some discussion going, especially on tibial tubercle osteotomy. And now we have Ridian also has joined us now. Ridian has about a half-an-hour window before he goes into his next case. Ridian, thank you very much and welcome. Can you hear us?
I must say, Dr. Ridian has written about the tibial tubercles.
That's right.
And he had described his approach with taking away the metal and using the 5-ethic bond, even for reattachment.
That's
I was quite impressed, but didn't have the guts to do that, still depending upon the screws at this time.
Yeah,
Yeah,
so I just wanted to... Yeah. Yes, Ridian, go on, please. Go
no,
on.
I was going to say, so the reason I started using sutures as opposed to screws was when I started using sleeves and cones. Getting a good screw through or around a sleeve or a cone is difficult. So it was out of necessity. But these days, it's always a suture technique, and I'm comfortable doing it. And we have no post-op rehabilitation issues. full weight bearing free movement.
Correct. Vidyan, and I read your paper and also seen you demonstrate live in one case. Your osteotomy is pretty small. It's about maybe 3 centimeters and maybe a couple of millimeters thick.
So it varies. So my standard one is about 6 centimeters.
Okay.
But I do a variation on it depending on how much exposure I need. So I'll either do 6 to 8 because I need a big exposure to help explantation, or I might go fairly small because it's just a matter of exposure.
Wow.
And the key though is to keep that lateral sleeve intact, just like that video showed. You're opening it up like a book, you're keeping the vascularity, the lateral sleeve, then you close it, and then that lateral soft tissue cover reads as a union and your fixation.
Correct. So let me take Amar in loop here. Amar, are you there?
Yes, I'm here.
Yeah, Amar, so how do you do your tibial tubercle osteotomies? What are your indications and how do you fix them?
You know, to be honest, I really try not to do them because of the risk of non-union and tubercle breakage. So I much prefer to do a quad snip and do some large gutter release, take out implants and mobilize my knee that way. I do agree you can use sutures to close these. There are very strong sutures nowadays, fiber wire, fiber tapes that can really be helpful. But I think the need to do the tubercle osteotomy, in my opinion, everyone has a different threshold, but it's very low on my list. I think you can, with proper soft tissue exposures, can almost always expose a knee.
Right. Any of the other faculty would like to add some points on tibial tubercle osteotomy?
Anup,
You like to add? Yes, Rajkumar.
I have a question.
after seeing Ridian Morgan Jones doing a couple of revision cases in Ganga revision course,
Right.
and I also started using the Ethibond, which is very, very handy. And I have almost found that it is very, very useful. And I did not have any non-union after that. And the only thing is you have to do a pre-drill, make 2 holes to pass the Ethibond before cutting it, so that the holes match when you resuture it. And the another thing is, unlike UK bones, our bones are very soft and osteoporotic. We have to be very careful in reflecting the sleeves. Use 3 osteotomes and gently reflect. If you see Ridian doing it, he routinely does that, but we have to be little careful. That is the point. But Ethibond works well.
Yeah, it does. Provided your osteotomy is not that big. Suri
Yes.
showed a conventional osteotomy, which you may need, in more stiff knees. So Suri, you talked about passing the wires behind the stem. Is that always possible? Because sometimes you're using hybrid type of cementing, and then you may not be able to really pull that wire and tighten it. So
No, this was done in the earlier times, maybe in the before 2010, when we were doing a couple of them. I did. It was cumbersome, but that is a robust way. If you use it over the stem, it cuts through when you tighten it. So the only insurance to prevent that cut through is to have the wire behind. So loosely get the wire holding. I think that is a tricky thing to do, but that will ensure that at least the wire doesn't cut through in the bone and just holds it in place.
And what about the knots? They have to come lateral, not medial.
Lateral knots, because there is some tissue to bury it.
Correct. Correct. All right. Yeah. Are there any questions from other faculty, or we can go to Ridian's talk?
Anup, may I ask something?
Anup,
Of course, please go ahead. Yes, please.
Anup, for the tibial tubercular osteotomy, unless you proximalize the fixation, the tuberosity fixation,
Correct.
you aren't really lengthening the quadriceps.
Correct.
So a stiff knee will not gain movement unless you proximalize the attachment. And if you proximalize the attachment, then effectively you are weakening the quads. So they should have some amount of lag before the slack is taken up. Am I correct or am I wrong in understanding this?
Suri, you want to take that?
Yeah, I think by the osteotomy by itself is only for exposure. It is not basically to balance the quadriceps apparatus. Whatever sort of a quadriceps benefit you get is because you're excising the scar completely. You're freeing up the gutters in both the sides and then bringing the tissue back. But as a default, when you finally do it, sometimes it migrates. You don't make a conscious effort to proximalize because that is not the endeavor of the procedure. The osteotomy basically has been done for exposure, not for lengthening the quadriceps. So if you have a significant patella bar, it will go up about 3-4 millimeters. You can't let it go again for about a centimeter or plus, because that will then impinge on the poly and other issues. So don't work on that. If it comes up by itself to a point which is stable, accept it, but don't force it to a proximal point. That's not the purpose of the osteotomy.
So in the cases in which it has proximalized,
yes,
do the patients have a higher degree of lag for a longer period of time, or that's not the case?
Lag was seen in quite a few cases, at least in the first 6 to 8 weeks, the last 10 to 15 degree lag, but it resolves in about 4 to 6 months. That's what I mentioned.
Thank you.
So
these are all the 40 cases with less than 40 and with difficult stiff knees. So you accept that the weakness and the time for it takes for it to restitute itself.
Yeah, I think the stiff knee is, certainly in Northern Europe, it's something we don't see that often. And I think it is difficult to get a good outcome. I've often had cases where I've created movement, but then the patella tightens. So it's a secondary to a baha. They end up having the condyles butting against the lower end of the quads mechanism. I think a stiff knee is a very difficult scenario to get good outcomes. And I don't talk very much in my lecture, but certainly my colleague Andrea Baldini is very keen on doing complete allografts, and he may have a very sensible rationale for doing that. It's a very difficult technique, and the stiff knee is a complex case, and I don't have all the answers. I really don't. And in fact, I'm happy to learn if anybody can tell me how to deal with stiff knees.
Anup, may I make a point?
Yes, please, sir. Yes, please.
One of the ways to gain movements in stiff knees is to free up the quadriceps tendon. And you can actually subperiosteally go all the way almost up to the isthmus by, you can go subperiosteally. And like Suri mentioned, it's creating the two gutters and excising the infrapatellar scar tissue that gives you the most decent range of movements. And we have adopted this release of the quadriceps tendon. We've been doing it for about 8-10 years, and it gives very gratifying results. It increases your flexion range by approximately about 15 to 20 degrees, which in a stiff knee actually matters a lot.
So how do you do that? You take a scissors and go right.
I actually take a Bristow or a osteotome and actually run it up the anterior surface of the femur. You don't want to go medially because that's where your blood vessels, the femoral vessels are, but you can go laterally and you can go anteriorly. And you can go a long way up. Actually, you should be able to put your fingers all the way up, up to the isthmus and free up the entire attachment of the quadriceps to the anterior surface of the femur. And that releases and allows the expansion to actually go down and increase your flexion range by, as I said, anywhere between 15 to 20 degrees.
Right. Amar, you had a point before we go on to Ridhian's talk?
Yeah, I mean, I was going to say that, most of the time when you're dealing with these stiff knees, you have to have a plan. And the plan in my mind is usually I'm going to put a hinge in. So if I know I'm going to go to a hinge, I'm very aggressive with releasing the medial soft tissue sleeve distally. And then I might even release it, proximally, right? And as you externally rotate the leg, the quadriceps it falls out of the way. So I think it's, if you're like, I'm trying to preserve the ligaments, these knees are impossible and you got to do a TTO. But if you're like, I'm going to put a hinge in and I can, sacrifice the sleeve and do that kind of peel, then you can get your exposure.
Correct. Right.
Yeah, I think that's a great point. And with the stiff knee, it's almost, but it can be purely an extensor problem, but often it's a capsular problem. And you have to go almost circumferential. And I agree with you in terms of, look, if you release radically so that you've destabilized everything and use the hinge to stabilize it, you can release off the posterior wall of the femur, you can release medially, laterally, anteriorly, you can do as much as you want to, but you then create stability through the implant.
Right.
Exactly.
Correct. That's a great point, Amar. Okay, I think Ridhian, we can go to your talk now on how to reconstruct the extensor mechanism. What are the strategies? And how we can practically apply them, especially in our country.
Okay, so I hope I've the talk meets what you want. But I thought I'd talk about the extensor mechanism in the revision knee and go through everything from the simplest problem through to slightly more complex solutions. I'm thinking about it. There are about 7 things to worry about. The patella, at revision, do you replace, do you revise? What about the post-patelectomy patient? Patella fractures, tendon ruptures, quad ruptures, extension, flexion, contracture, stiffness, as we just just discussed. And then salvage, what happens when you've lost everything in the extensors? And I'll go through each one in turn, giving a little bit of my philosophy, and certainly hoping to get some feedback and to learn a few points here. So the patella, I'm not sure what you guys do. I'm very selective in my patella resurfacing for primaries, slightly less so for revisions. My threshold changes. But for me, the question to replace or not depends on the patient's symptoms, my personal belief. Revisions, simple ones, I may not. The re-revisions, I probably would. And in terms of if there's a patella, do you revise or not? Preoperative assessment, are they symptomatic? Are they loose? Is it infected? And often at the re-revision, I see a lot of this stuff, the lateral facet, where that's an undersizing of the primary patella or simply bone overgrowth after somebody's released it. But a lot of the cases I see have this lateral facet, which we release, and that'll help your alignment post-surgery. Top tip would be to decide early on in the revision. So revisions can be complex, they can take time, and I find it easier to decide on the way in what I'm going to do with the patella. If I've had a big revision and I'm deciding on the way out, I'll decide to do very little, and I often ignore the problem, and I've regretted that a few times. So with the patella, make a decision on the way in early on. Here's an example of a overstuffed patella. We revised it, but I left the patella as native. By sorting out the joint line anteriorly and distally, we've gone from a relative baha or a secondary baha to restoring height, and we never replaced it, and the patient didn't need it. It was about getting the mechanics right for the patellofemoral joint. In this case, a one-stage re-revision for infection. We got infection all the way through the joint, including underneath the patella. So it's a very easy decision to redo that at the same time as I'm doing the distal femur. Patelectomy patients, I'm not sure whether you see many patelectomy patients anymore in your practices. Certainly in the UK, if we went back 30 or 40 years, it was a very common and I think a necessary treatment for knee pain. And it's left a legacy when it comes to both primary and revision surgery. So what are your options? Well, you can ignore it. And if you've got a good functional patelectomy tendon, I think that's a reasonable option. Quite often you see the tendon having split either over one condyle or another. And then I try and do a variation on an insult 2 procedure, releasing medially, mini release laterally, overlapping. So you produce this tube which tracks up and down the trochlea and has a little bit of height to give you some lever arm. The metal augment I've used in primary situations a couple of times, the Zimmer TM augment, and I found it quite disappointing. I think it works best if you have a shell of bone, so you get some bony integration. Using fiber wire to stitch into the patella tendon, I've had a couple just sheared loose. So I tend to avoid this these days, although I have used it in both revisions and primaries successfully. Allografting, I do a little bit of this. I was told beforehand this is not widely available in India, so I'll purely mention it in the fact that you can use allografting. I've tended to use tendo Achilles allografting because it's easier. Getting a full quads patella tendon tubular allograft is very difficult in the UK, although it's getting a little bit easier. And I tend to use a trapdoor technique where I'll bury the bone of the Achilles tendon graft into the proximal tibia, close the trapdoor so the wires are all beneath bone so they don't get irritation, and suture the tendon into the quads above in full extension. That works reasonably well. Possibly allografting extensor mechanisms might be better. These days, my go-to, if I've got a patelectomy patient and it's a primary, is to autograft. And here's an example of a male 30 years on from trauma, distal femoral non-union, union, 30 degrees of varus and a patelectomy. So we did a osteotomy, use the sleeve and stem to fix the osteotomy, and we use the medial femoral condyle, the distal cut, as our autograft. And you reconstitute the patelectomy tendon either with a tube or if it's in good condition, just as it is, make a little pouch, slip it in, oversew it in the right position at the right height. And that gives you increased lever arm and gives you a neo patella. Here's the patient at 12 months, and that's his 12-month x-ray. And you can see vascularization of the distal femoral cut from the medial femoral condyle. The lateral femoral condyle tends to be too big, too long. I tried on a couple of cases and I had one that fractured in the middle before it went on to unite and vascularize. So medial femoral condyle is the right size, and you put it at the right height in terms of the tendon, it works very nicely as a neo patella. So that's a nice, easy, cheap, even a free tip. Patella fractures, we see a fair few in the UK, and I don't think classifications has changed a lot over the recent years. We talk about extensor integrity and implant fixation. So it can be type 1, stable implant, intact extensors, type 2, stable implant, extensor disruption, and type 3, loose implant. And based on those three classifications, you can decide how to manage. Most, I have to say, are well fixed implant or a native patella, and a large majority are undisplaced. And if they're undisplaced, as in this case, I'll treat them closed, I'll immobilize them for a period, I won't look to interfere, because there are risks. Internal fixation is often done, I think, not as well as it could. It's done out of hours, it's done by juniors, and you get a high complication rate. And often you don't have to do it. Here's an example where the extensors, despite being disrupted, actually went on to unite. And just by leaving alone, actually this patient presented late, so I wasn't given the option. But she presented 6-8 weeks after her fall, and her extensors were intact, so we simply left alone. This is the fear. Well-intentioned fixation leads to infection. And in this case, I had to revise the entire joint because my fellows had fixed the patella. Fixation went on to unite well, but the infection that resulted from the time of fixation and the trauma meant the whole joint had to be revised. So a little reluctant to fix unless I really have to. More of an issue, I think, is the soft tissue rupture, either tendon below or quads above. And these tend to be either intraoperative or postoperative. And the intraoperative are because of an aggressive dissection, over vigorous retraction. It's your fellows again, guys. And one of my indications for an osteotomy is to avoid that aggressive retraction of the patella tendon. That will lead to, once in a while, a rupture. If it happens intraoperatively, you need to do an immediate repair and augment the repair. Postoperatively, same thing, repair it and augment it. Some I see are iatrogenic, and here's the example that genuinely upsets me when somebody's done a first stage, put in a cement disc, a spacer that's unstable, and it comes out and takes out the extensor mechanism. I wrote up a series of these a few years back. It's an unnecessary disaster, because when you've got infection, you may have not cleared, you then add in an extensor rupture. It's a very hard get out from these problems. Tendon ruptures, if you identify them early, repair them early and augment. Augment with wires, fiber wire, add in a hamstring graft if you need to. Late and chronic ones, you're lucky if you can get in and then reduce the patella height adequately. There's always going to be a little bit of patella alter. It's difficult to bring it down and keep it down. If you can do it, add in hamstring graft. Think about allografting, think about medial gastroc flaps. If it's a really chronic rupture, you're trying to rebuild. And then immobilize for a period. Allografting, again, if you're going to do it, you need to make sure that you bring the kneecap down to a good joint. And this is a case of one of my colleagues who did the revision, put in a 25 or 30 spacer, and the knee simply ruptured as he bent it. My colleague went in, allografted, and left the implant in situ, and the same thing happened again. So if you're going to allograft, understand why it happened, and this is entirely iatrogenic. Quads ruptures, pretty much the same as the tendon. If it happens acutely on table, repair it and augment it. It can happen afterwards with forced flexion. Patients often present with an acute failure of extension. This is where I think those late presentations need to be seen by the surgeon. There's a big vogue in the UK for post-op follow-up to be done by physios or nurses. There's been a number of these cases just been missed, and you end up with a much harder late reconstruction. If you see it early, repair it and augment it. If it's late with a big Baha, you've got to reconstruct, and it's a much more difficult case. So here's an example of a post-op avulsion here. Immediate repair and immobilization, and the patient did well. Here's a case of very late rupture, complete Baha. We stuck down on here, and it's a very difficult situation. But in this case, it was late, and we lost the extensor mechanism above. And we also had a problem of infection. So we did a major one-stage, taking out the implant, rebuilding it, allografting, and doing a medial gastroc pair and grafting to cover the front. And a medial gastroc flap can be an amazing friend to you if you know what you're doing. This is a pedicle flap. So we release it from the posterior of the femoral condyles above and from the tendon Achilles below, and you pedicle it and rotate it to joint to the quads above and to the tibia below. And this will give you continuity, but it's not, I think, enough by itself to give you good, strong extension, and you often need to build in a graft of some sort. Now, it can be a tendon Achilles graft, it can be synthetic. Synthetics I've used have been difficult because you're in this scenario where there's very poor soft tissues. So if the soft tissues are poor, think about revascularizing the area with a medial gastroc flap, and you'll get some reasonable results. These slides I borrowed from Andrea Baldini in Florence, who I think has probably the largest world series of extensor allografting. And I've seen Andrea talk a number of times, and his results are amazing. I can't get it to work quite as well, I'll be honest with you. Maybe I don't do enough. So this is a re-revision, allografting, medial gastroc, and a one-stage revision all in one hit. It's a good 2.5 hours of surgery. We mentioned this earlier, contracture. I think arthrofibrosis is a genuine condition, but it's pretty rare. I think most of it we see are the results of multiple operations, multiple revisions. Certainly I see a group who warfarinized and had hematomas, and this occurs. Most stiff knees, though, that I see, certainly stiff primaries, are the result of mismatch of the joint and soft tissue balancing. So I think arthrofibrosis is overdiagnosed. Most stiff knees are mechanical and can be revised fairly straightforwardly. True arthrofibrotic, though, is difficult, and I would urge an extensile approach, and I tend to do tibial osteotomies with a very low threshold. I try not to do a quads turn down, but I will do a quadsplasty, and I'll, much as we talked about earlier, osteotomy on top of the femoral condyle, releasing underneath it, and I'll go horizontal to release the quads, then I'll go vertical, splitting the quads tendon underneath the skin, and the whole of the quads then peels off very, very nicely. If you're going to use a hinge, you can play with the joint line a little bit, maybe 4 or 5 mils upwards, to create space to extend and bend into. But I think a hinge is really going to help you if you're going to try and deal with the most stiff knees. And I counsel that you shouldn't be afraid to use a hinge. It's a great indication. In terms of the approach, much as you've heard earlier, osteotomy to do a low energy typical tubercle osteotomy. You do a quads release above, and think about doing a capsulectomy posteriorly, because the contracture isn't purely in the quads mechanism, it's circumferential, and you have to be prepared to release medially and laterally, as we've just heard, but also posteriorly. Really work that posterior capsule, release the contracture. And sometimes you've got to get in there and take out this calcified tissue all the way around to give you a capsule that allow the extension and give you space to flex into. And lastly, the one we don't want, the salvage scenario. From my own unit, a colleague of mine, good surgeon, did a complex primary. Patient fell day 3 or 4 post-op and sustained this injury. And as you bend the knee up, you see a complete loss of the extensor mechanism. So this is an elderly patient. It's now infected. We've got no extensor mechanism. Young adult, maybe you think about reconstruction. The elderly, you want one salvage. And for me, that was an arthrodesis, long nail. I used a negative pressure vacuum. These days, maybe I do a gastroc flap, but actually it went on to heal well. Went on to unite with no other surgery. And although it's a difficult scenario for an elderly patient to walk with arthrodesis, it kept them home, kept them independent. And it's a reasonable salvage option, but you'd rather not go there if you can avoid it. So I've gone through fairly quickly 5, 6, 7 problems you can encounter with the extensor mechanism in primary and revision knees. I'll be honest, I'd rather take an infected re-revision than an extensor mechanism failure. I think it's difficult, and I think there's no one good solution. You have to consider grafting, allograft, autograft, synthetics. You need to consider quadriceps work. You need to consider gastroc flaps. And even then, your best result is not as good as it could have been had your primary extensors been there. So guys, if you've got any advice you can offer me, I'd be more than grateful to have them off you. Thank you.
Brilliant. Thank you for that very comprehensive review of all the problems, possible problems and solutions that can be. Let me take in some other faculty and ask them if they have any points to add or any questions to ask, any comments. Anybody, please? Yes, Nilen.
I think this talk about patella fracture post total knee when they are fixed. I don't know whether the rest of the faculty has the same incidence of infection as it is generally talked about. I know that most people say that sometimes it is so serious a condition that one should consider an extensor allograft, which as we don't have here, I think most of us have fixed these kind of patella fractures. And at least my personal experience has not been as bad as it is portrayed out to be. I just wonder what the other faculty members also feel. And I know the Western experience is quite dismal with this.
Yes, so certainly there's a paper from Leeds, Giannopoulos, a few years back, reviewing the published data, and the advice was very clear that if you can leave alone, leave alone. But you can't leave everything alone. You know, a proper extensor disruption, you have to reconstruct early. I think the point I was trying to make, and maybe I didn't make as well, is it's not necessarily a benign procedure if it's left to a junior to fix at some out of hours. So if it's my case, I fix it. And I take responsibility for it. I've certainly in my region been sent absolute disasters from well-intentioned internal fixation, some of which I've been able to reconstruct and revise. Some have ended up with arthrodesis because of the first intervention was disastrous. So I'm a little coloured maybe, but I take your point. If you've got to fix and repair, you fix and repair. But maybe it's you that does it, not your junior.
Correct. I agree with proper techniques. Yes, sir, please.
2 points. One is in a patient who has a shell of a patella, doing this gull wing osteotomy is a reasonable procedure. We've actually had experience of putting a TM augment, and that was really quite a challenge and quite a disaster. So the first message I'd like to put out is augmenting with things like a TM button is more for historical. It's something that really should not be sort of put into consideration. The second point to Radian's presentation, thank you, Radian, that was an excellent presentation. We've actually published on the patellar tendon disruptions in the revision situation. And what we have done, since we don't really have access to allografts, is to use a strip of the quadriceps tendon with a segment of the patella, and we reverse it and use that patellar segment as the insertion point for the tibal tubercle. We then split the extensor tendon, the quadriceps tendon, and augment it with a semi-T. We've reported this in the Journal of Knee Surgery, and then we did a follow-up of this article about 3 years later. And we did a article in conjunction with your friend Andreas Baldini, where we compared the allograft with our technique. And while I agree the general outcome of most of these procedures is fair at best, but for fresh ruptures, the autograft technique seems to do quite well. And for the more chronic ruptures, either the Achilles tendon or the extensor tendon allograft does well. So that was the conclusion from our paper with Andreas. And we have now got a follow-up of almost about 5 years, and it seems to be doing reasonably well. Yeah.
Actually, it's a great tip, and you know, I've actually used the quads graft mainly for ACL revisions at times, and it is a very robust graft. And I think the point you made is a good one. You know, recognize it on table and sort it out on table. The acute is a different outcome to the chronic case. Yeah.
So yeah, I think we have to individualize the case and see how the case is, how the soft tissues are, and what the options are, from local flaps to allografts. Right, Vivian?
Yeah, absolutely. Yeah. And it is, honestly, it is case by case. And maybe could ask Amar out in New York. So I think there's a very good series of synthetic extensor mechanism reconstructions that I'm not sure whether it's HHS that published that or one of the other colleagues in America, but I've certainly heard talking about grafting, cementing into the proximal tibia with good outcomes. Have you much experience with that?
Yeah, that's the Mayo experience, and Dr. Arlen Hansen. You know, I think it works well in terms of getting that fixation. As you said, you can cement it inside the tibia. You can put a screw then through it as well to reinforce it. You know, I think you said it best, though. I mean, at the end of the day, managing extensor mechanism problems is by far and away the most difficult thing we have to do. And all these procedures are just, you know, variably successful techniques to try to get you out of it. And the lesson that we should really teach is not what to do when you have it, but how to prevent it. Right. You know, how to prepare your patella, and so you don't, you know, overcut your patella, how to not avulse your tubercle, how to not, you know, create these problems, because, you know, solving them is not easy.
No, absolutely. And one of the vogues in the UK now is moving towards revision networks, so that there's a hierarchy of who does the most complex cases. And certainly I've taken on from good surgeons, but maybe not experienced in revision, disasters. And it's always the wound breakdown extensors that go. And you know, prevention, absolutely. If we can prevent problems, we should. And maybe that's a big teaching point that we take away from this, that prevention absolutely is better than any solution I have to offer.
And I agree with you 100%. You know, even, you know, at our institution, you know, the younger surgeons tend to get the more complicated cases, you know, the periprosthetic fractures, the extensor mechanism disruptions, because, you know, the time and the care and then the reimbursement don't match up. So the senior surgeons don't want to do it, right? And I agree with you that it's not necessarily always in the best interest of the patient, because sometimes that experience is what you need to get out of these problems.
Great points those. Now let's go on to the next talk by Krishna, and let's see how we need to balance a revision total knee, how to go in a sequence to balance a revision. Yes, Krishna, please.
Can you see my screen, please?
Yes, we can.
Thanks, Anup, Dr. Mohanty, for inviting me. This is a pretty basic but important talk on reconstruction in a sequence. So the first step is to establish the tibial platform, and this is important because the tibial cut influences both flexion and extension gaps. Of course, you have a significant amount of bone loss in certain cases owing to the mode of failure itself, due to removal of implants or polyethylene wear-induced osteolysis. Therefore, minimal bone must be removed to establish a flat tibial surface. And one must not sacrifice good bone to eliminate the bone defects, because then you will go way below the required position of the ideal tibial platform. The intramedullary rod preparation and trial assembly is done. Essentially, this is done at what you think is the correct level of the tibial platform, typically a centimeter or so above the level of the tibial tubercle. And this will give us a fair idea as to what is the amount of bone loss and where you need to do the reconstruction part. It is important not to overcut the tibia because, as we've seen from the previous biomechanical studies, as we go down from the tibial plafond, as we reach around 3 centimeters below, the strength of the tibia decreases by around 300%. So it's not supportive of an implant for long-term fixation. So this is the reason why we should not undercut the defects. Just like in primary revision, also the same fixation principles hold. We have three zones for tibial fixation: the epiphysis, metaphysis, and diaphysis, which will be covered in the due course of time. Sometimes you may be able to get away like this with implant removal, but extreme care must be taken during retrieval of well-fixed implants to prevent further bone damage or unnecessary loss of good quality bone. What you must then do is use either a extramedullary or an intramedullary guide to just achieve a sort of a flat surface, removing the minimal amount of bone possible. Do your stem preparation to achieve some sort of diaphyseal fixation if you're not using sleeves. And set your tibial platform, and it will end. The next step is to stabilize the knee in flexion. This is based out of 3 important points. One is the femoral component sizing. The second is the femoral component rotation. And third is the collateral ligament balance and tension. The femoral component sizing must be based on the retrieved component if the retrieved component was adequately sized to begin with. The most common error is trying to fit the component to the existing bone, which is usually deficient and which will lead to undersizing of the femoral component and laxity in flexion. If you are not able to optimize the component position in the anteroposterior or mediolateral position, there is role for offset stems. You can also use the templating of the contralateral side if it has not been operated to get the adequate size of the femoral component. Now, the femoral component rotation is again important, and we do not have adequate landmarks because the posterior condyles are generally deficient, and it is usually based on the transepicondylar axis, which usually are intact in most of the revision procedures, where you can palpate the medial and lateral epicondyles and set the femoral component parallel to the transepicondylar axis. And in a tensioned knee in 90 degrees of flexion, you can also position the femoral component parallel to the cut tibial surface. So this will give us an idea as to what is the amount of flexion gap in that particular patient. And now the important point is to determine the function of posterior augments. So this is how a posterior augment looks like. If you have situations where the component rotation needs to be increased, then you can use an isolated posterolateral augment. But if you have a situation where you have to oversize the femoral component and there is no bone support posteriorly, then you may have to use posterior augments on both the sides, depending upon the situation. This is a typical example where you will have to oversize the femoral component to take care of the flexion instability type of situation. And this is the situation where you will have to use a larger size femoral component, preferably in a little bit of flexion, using posterior augments in order to tighten up the flexion gap. This is how a loose knee in flexion at the time of revision appears. You can see an 18 millimeter insert, and even that the post is dislocating. So you can see that the knee is extremely loose in flexion in this particular case. So the strategy in patients where the flexion is loose but the extension is all right is to upsize the femoral component, to cut the tibia at a 0 degree slope and try and proximalize the tibia wherever possible. And this is usually not possible without the use of some sort of sleeve on the tibial side. So although that is not the brief of my talk, this particular case was managed by not only upsizing and augmenting the posterior femur, but also proximalizing and neutralizing the slope of the tibia by using a tibial sleeve. The key step for decision making is the ability to achieve a balanced flexion gap. If for some reason we are unable to achieve the balanced flexion gap due to collateral incompetence, then one must have to consider upping the constraint and sometimes using a hinge where you are unable to equalize the flexion gap using the thickest poly available. The joint line is not very clearly understood in flexion, but it is important to match the prosthetic joint line to anatomic joint line in 90 degrees of flexion. So how do we do this? The joint line is just below the level of lower pole of patella. If you have two different femoral components which are able to achieve a balanced rectangular flexion gap, you must choose the femoral component and polyethylene thickness where the lower pole of the patella and the relationship to the joint line, which is the intersection between the posterior femoral condyle and the articular insert, is just below the lower pole of patella. That is how you must choose the joint line restoration in flexion. Typically in revision, bone loss and use of stems in the femur can compromise the ability to evaluate and restore the joint line in flexion. If you have bone loss, you may have to use the posterior augments. And if you use stem in femur and a long stem at that, sometimes because of the anterolateral bowing, the femoral component can be anteriorly translated. This is where you must look at the use of offset stems or a shorter stem, which can be better controlled in the anteroposterior direction in order to optimize your flexion gap positioning. Joint line restoration is crucial for flexion extension gap balancing and also to avoid mid-flexion instability. Several landmarks have been described in literature: the medial epicondyle, lateral epicondyle, the adductor ratio, where you look at the 0.52 of the medial-lateral width of the distal femoral surface is the individual distance between the adductor tubercle and the joint line for that particular patient. You have the fibular head and the tibial tubercle. These are all the landmarks which are available with varying distances depending upon the individual patient. Now, the third step is femoral component position to stabilize the extension gap. This is typically straightforward. Usually there is recurvatum because of loss of distal bone, and this is managed by distalizing the femoral component. That is how the thing will look at the time of trial. The flexion gap is balanced, but the extension is loose because you have lost some distal bone, and by distalizing the femoral component using these augments, you can achieve full extension. So you must not leave the knee either in recurvatum or with a fixed flexion deformity. Rare situations in patients with fixed flexion deformity, it will require additional distal femoral resection in order to balance your flexion extension gaps in the revision scenario. Depending upon the constraint of the implant, it will tolerate elevation of the joint line by between 5 to 7 millimeters, whether we are using a varus valgus constraint versus a hinged implant. If you increase the joint line or elevate it by more than a centimeter, then the patellofemoral joint will have issues. So by augmenting the distal femur, we are able to tighten up the extension gap, and you are able to achieve a knee which is fully extended without any recurvatum or fixed flexion deformity. This is the case example where you can see there is a hyperextension of the knee and which has led to the failure. And by distalizing the femur using distal augments, we are able to achieve a balanced extension and flexion gap. The role of constraint is considered after the principles of flexion extension gap and collateral ligament balancing are followed. And if stability is not achieved, progressive levels of constraint must be tested and used as and when applicable. Thank you very much.
Great, Krishna. As usual, all the points are covered. Let me start the discussion by asking you, when would you consider a full thickness tibial augment? In other words, what's your maximum limit of poly size after which you will be concerned and you will go to a full thickness tibial wedge?
Yeah, it's a great point, Anup. I'm not comfortable putting a poly beyond 17 millimeters. That is when I would, I would think about something. Nowadays, I do not do tibia without a sleeve. So I would use the sleeve to position my tibial platform. And usually my polyethylene thickness is way below 17 millimeters. So I haven't had to use a full thickness tibial platform after I switched to the tibial sleeve. So currently my practice, I do not do a knee revision without a tibial sleeve, especially in situations of significant tibial bone loss where you have to use a tibial platform to get a thinner polyethylene.
Correct. Any of the faculty would like to add something to the tips of soft tissue balancing of a revision knee? Yes, Amar, please.
Yeah, so I think the take-home message, I want to go even back to the primary knee, is the concept that we always teach, which we want equal, flexion and extension gaps, right? That's sort of the first rule of a knee replacement. I will argue, though, that actually is not true. In a PS knee, I want a flexion gap that is slightly smaller than my extension gap, meaning 1, 2, 3 millimeters smaller. Conversely, in a CR knee, I'd want it to be 1 or 2 millimeters larger than my extension gap. I will tolerate in both cases equal gaps, but those aren't ideal, right? And especially if you're doing a PS knee, you want that flexion gap to be snug on the primary. So when you reduce that knee, you really hear and feel that thud when it goes in. And I think if you get that, achieve that, you'll have a much lower rate of instability in the revision setting.
Correct. So very same in revisions, your flexion space a little tighter than extension or otherwise?
You know, so I think most of the time in a revision, you're going to use a constrained knee. So you have a little bit more freedom with your flexion gap. But certainly, I think if you can achieve a snug flexion gap, that's the way to do it. What I wouldn't do, however, is to achieve that stability and flexion by raising my joint line. That's not the answer either.
Correct. Manoj, yes, please.
So Krishna, there is one message I want you to infer. In one of the cases you saw using distal augments. So when in distal augments you use a stem and where you do not use a stem while using distal augments?
So I have a low threshold for using a stem whenever it's a revision type of scenario, Manoj. So if I'm using a distal augment, I would always stem it.
Correct.
My practice.
That's the broad rule, yeah. Okay, so maybe we can go to Amar's talk now on fixation with sleeves. And Amar is published on it, is very fond of it as well. So Amar, over to you, please.
Sure. Let's see if I can get back here. Can you see my slides?
Yes, we can.
Okay, great. So yeah, I'm going to talk about sleeves. I've obviously had a lot of experience with it, and we have a long experience with DePuy. We don't actually have any relationship with DePuy on this product, but I do have some conflicts clearly. So I'm going to just go through quickly how I handle most revisions nowadays. I start off with preparing the tibia, then I'll do my femur, lastly my patella if it needs to be done. I always focus on trying to restore the joint line, reconstruct the bony defects nowadays, mostly with sleeves. And then when I do my ligament balancing, I think it's very important. I always use PS trials. You know, I think you have to open up a separate tray to get those trials if you're doing a TC3 type revision, but it doesn't do you any good to use those TC3 trials because you need to know your soft tissue balance. So the technique in using sleeves, it seems relatively simple, right? You're just going to ream distally. I often will do it on power to get your endosteal fit. Then you ream proximally to open up the proximal tibia. And then you broach till you get stable fixation, just like you would in a hip. And then you can cut off that broach to level out your tibia. Now this looks all very, simple, and this is what you would do if you're doing it in a cadaver. But if you're doing it in a revision, there's sclerotic bone, there's retained cement, there's a slew of reasons why this technique doesn't always work in the revision setting. On the femoral side, it's very similar. Ream to get endosteal fit, open up the distal femur with a proximal reamer, and then again, broach until you get stable fixation. My preparation pearls. The broach is the least important thing. And if your broach is not advancing with every tap, just like in a hip, you have to do something else. Either ream more, or I use a high-speed burr to remove sclerotic bone and to make sure the broach for me, the broach is more of a sizing tool than a bone removal tool. So you want to ream as much as possible and then broach gently. You want to prepare the bone, and it doesn't usually get prepared with the broach alone. Because if you are aggressive, this is what can happen. You can fracture on both sides, and then you end up having what you do in the hip, where you back out the implant, you put a cable around it, and you back it back in. So in order to avoid that, I think you really need to learn how to prepare the bone before you put the implants in. I started off cementing many of these sleeves in, then I went to sort of a hybrid situation, and now I put them in all without cement. The only time I might add cement is if I have very large defects and I can put antibiotic cement in just to deliver some antibiotics, but it's not used for fixation in my hands anymore. So I always prepare the MBT rotating platform revision tray. From there, I can put in a PS insert, a TC3 insert, or go to a hinge if that's what I need. So it makes easy conversion from the TC3 to a hinge. The only thing you have to be aware of is if you're going to put anything in, you've got to be able to take it out. So if these sleeves grow in, yes, you have to learn how to do a TTO, and you have to learn how to do osteotomies of the distal femur to get them out. So you want to think about how much porous coating you need, especially on the femoral side. They can be fully porous coated sleeves or partially porous coated sleeves. So I'll go through a few cases here. This is a tibia that's obviously failed into varus. You can ream, you can get a sleeve. And you can see here, this was earlier on in my experience, I used cement underneath the tibial tray. But as I looked at these x-rays, I realized the cement wasn't really doing anything. You can see the gap between the cement and the bone. It's not doing anything. So maybe it's providing some antibiotics, but it's not, it does not have a role in my fixation. And if anything, I started to think it might even prevent my sleeve from settling in a appropriate position. Here's another case where the femur got loose and migrated out of the canal. We can bypass the defect, put a nice big sleeve in, and there's no cement in this. This is a free-flying femur. On the tibial side, the defect was not that great, so I think just a cemented tibia works fine. You don't need to use the sleeve in every single situation. I think that's a take-home, point. Cement works fine if you have good supportive cancellous bone. Here's a case of rheumatoid arthritis with very large cysts. As I opened up the knee, the condylar bone was fine. There was a deep cyst behind the femoral condyle. And then the tibia, almost all the condylar bone was gone. So I felt on the tibial side, again, I'm going to put a sleeve in, right, without cement. It fit perfectly. And on the femoral side, I just put in a cemented stem with hybrid fixation, and it worked fine. So again, you don't have to use a sleeve because a sleeve on the femoral side would take away a lot of condylar bone. Very difficult two-stage revision that came from another hospital, still infected. There's no way if this woman could walk on this type of situation. So we took it out, cleaned everything out, put in what I consider to be a spacer. This allows her to walk. There's no cement in there. We put beads in originally, but she's able to walk on this. And in fact, 5 years later, she got reinfected. We took this out. None of the parts were well fixed. We autoclaved it again and put it right back in with a new insert. So she's been able to walk on this with a controlled infection, not an eradicated infection. So we talked about how we classify this. We gave it 3 grades. Grade 1 is an osteointegrated sleeve. Grade 2 is not osteointegrated, but it's stable. And then you just determine how much of it, is it more than 50% or less than 50%. And then 3 is not osteointegrated and unstable. And how much it subsides determines 3A or B. So in our first 20 cases, this is back in like 2008, we looked at how well these sleeves were performing. And we realized, on the femoral side, 18 cases were grade 1 and 2. On the tibial side, 17 were grade 1. So, you can have some subsidence. These are difficult cases. But if you learn how to put the sleeves in, they will seek usually a stable position. So I'll go through a couple of cases right now with really complex revision settings. This was a 56-year-old woman. She was on chronic opioid therapy. She had multiple knee surgeries, initial surgery in 2009, Lateral exchange in 2013, revision in 2014. She had a very stiff knee. She had loosening of both her components. We worked her up, and at the present time, she was negative for infection. So these are her x-rays. You can see she has almost no proximal condylar bone on the tibial side. She's got good cortices, both proximally and distally. So we try to template how we can get a sleeve to go in there. And luckily the sleeves come in all different sizes. and you can usually find a sleeve that will work. So, we ruled out infection. We evaluated the bone loss with CT scan. We worked on our approach as we talked about. We did a quad snip, a wide exposure. We took all our cultures and debrided the bone. I even used the mini C-arm just to make sure I was going in the right place, and I was able to bypass this defect at the bottom and get down into the endosteum. So this is the reconstruction with a hinge and sleeves on both sides. There's no cement in this construct. One of the keys here is using a stem size that is 14 millimeters or less that allows you to pull it through the sleeve. So if you do get infected, you can more easily get it out. But I was able to use a thicker tibial base plate to give me some height. And you can see I don't want it even resting on the bone. I don't want the base plate resting on the bone. I want the sleeve taking the load of this construct. Here's another case, 67-year-old male who had multiple infections, spacer, reimplantation, went on to failure. And this was complicated by the fact that his opposite leg was a below knee amputee. He was already on chronic antibiotics. He had diabetes, obesity, coronary artery disease, had only about 10 to 60 degrees of range of motion and gross instability. So you can see the loosening of his implants here, the bone loss in the distal femur. He's already got a shell of patella only, and you can see his amputation on the other side. So this guy needed a good leg, something that he could stand on and use effectively. So we put the sleeves in on the tibia, and you can see, there's a huge defect here immediately, but this is 4 millimeters of chromium cobalt. I have not seen one break. The sleeve can take all the weight of this man's body on the one leg, get good endosteal fit with a nice sleeve inside the distal femur. And I will tell you, the one risk this guy is going to have is failure at this junction. I've seen a few of the unsupported hinges and unsupported TC3s can fail at this junction, but that's something that we have to deal with. Oftentimes, it's an easy revision if that happens because the sleeve is intact. We just have to replace this component. So it's almost like doing a liner exchange, but that is a weak point if it's unsupported. So I think, you can do these revisions. I have a very low threshold to go into hinges. It does take planning and preoperative imaging. Obviously, infection is the biggest bugaboo, but that's why I like non-cemented fixation. If it gets infected early, these things will not grow in, and you can remove the sleeves very easily. Obviously, if they get infected later, then you have more challenging time taking out the sleeves. But you have to be able to expose and get the implants out with minimal bone loss and all the basic concepts of revision surgery. But I would say it's extremely uncommon now that I would do a cemented revision with fully cemented stems on both sides. So I think non-cemented fixation is here to stay. And because of my revision experience, it has driven me to now do much more non-cemented primary knees, which is the same thing that happened to us in the hip. So I think it's happening in the knee now, and non-cemented fixation is here to stay. Thank you very much.
Great points, those on sleeves, Amar. Can I initiate the discussion by asking you, as compared to offset stems, where you can use these stems to posteriorize or lateralize your femur, with the sleeves truly dictate your femur component positioning. Any tips on those?
Yeah, so I think the sleeves, if you're going to go for primary sleeve fixation, you've got to get the sleeve to go where it wants to go. And sometimes to do that, you have to undersize your stem that's associated with it. Because as the bow of the femur happens, the stem can force the sleeve into extension. So sometimes you have to go with shorter sleeves, shorter stems, or even just narrower stems. So in my preference, I like to go as long as I can get away with, and I'll often go narrower than what I reamed endosteally. Because yes, if it's relying on the sleeve has to make contact with the bone. And in the same way, like on the tibial side, I like to look under the tibial base plate and see light all the way through. I don't want to see the base plate hitting the bone because I think that prevents that minor subsidence that you need to get bony ingrowth. Right. So if it's touching the bone, especially posterior laterally, that is going to prevent it from seeking its path. So, you know, just cut the bone away or go up in sleeve size so that there's a space underneath that plate. And at first, if you don't like it, as I said, you fill it up with bone cement, but you realize it doesn't do anything, and it probably just prevents you from subsiding. So, you know, that's why if I want to put in antibiotics cement, I'll put it anywhere where it won't prevent my sleeve from, you know, sitting properly.
Amar, the smallest sleeve which is available is 29, and that is not coated. And you know, in small Indian ladies, when you do a revision, when you put it the smallest tibial sleeve, it is not coated, and hence you have to cement it. What is your opinion about it?
Yeah, I mean, I think
unless
if
it is
it's not
coated,
coated,
you can't leave it uncemented.
I agree with you. You know, all of these sleeves, and the sleeves and the cones for that matter, they are still in an area of technological advancement. You know, so I think we're going to get more sizes of the sleeves. We're going to get more porous coating options on the tibial side. So these things are going to come because we recognize, you know, these options. You know, but like I said, if I have good condylar bone on the femur, and I decide to cement the condyles, if I put a sleeve in, that's for secondary fixation. But if I don't have good condylar bone on the femur, and I'm just relying on the sleeve, I have to get that sleeve to fit, you know, perfectly. So I think if you have no porous coating in that size, yeah, you have to cement it in. That's just the way it is.
I ask something, Amar. Now, when you said you put a sleeve and there is a tibial base plate on the top, and when there is subsidence of the sleeve, maybe more than 2-3 millimeters, would it not change our gaps, the flexion and extension gap, because you are changing here the tibial side?
Yeah, I mean, I think if it's subsiding 2 or 3 millimeters, then you did something wrong in the preparation, and you also risk fracture of the tibia. I'm talking about that micro settling that you get when when you walk on your non-cemented hip, when you walk on your non-cemented knee. It's that force that it sees, you know, that allows the bone to grow into it. So it's settling, you know, micro millimeters, not 2 to 3 millimeters.
Okay.
Amar, in some of these extreme defects, which are oblique eccentric defects, when you prepare the sleeve, you find a segment which is uncovered. You find the sleeve area, maybe a little bit uncovered. Sometimes more often than not, it's medial. But laterally, posteriorly, is sort of covered. How much of sort of this uncover can we accept in the appropriate tibial height?
You know, I would tell you it's just like doing an acetabular component in the hip, right? I mean, if all you need is about 20% for ingrowth. So I don't care if half the sleeve is uncovered with bone, as long as that sleeve is stable when I'm hitting it, right? So if you hit it and it falls into varus, that's not good. That's not going to work, right? But if you have a long enough stem, and then you keep hitting it, and it stays in that position, as long as it's got some bone contact laterally, it's going to work fine.
All right.
Anup, can I make a point?
Yes, please.
From my own experience in Indian patients, I would like to make 3 points. One point is on the femoral side, it's very difficult to put a stem because the anterior bow is so much that oftentimes I've had to just depend only on the sleeve without putting any stem because it would not go in. The second point is if you're doing a TC3 type of implant, and Amar mentioned this, if it is unsupported, unlike on the tibial side, it's a junction between the femoral component and the sleeve. And the TC3 type is more difficult because you have a bolt going in and then there is multiple modularity there. So it is always a good idea to use augments both distally as well as posteriorly to optimize the femoral component contact with bone and it's not a good idea to leave it unsupported wherever possible. That's the second point. The third point is on the tibial side. Unlike an S-ROM hip, where you want the distal fixation, and it is sized distally, and then the sleeve is there proximally, and you want a snugly fitting distal stem, you do not want a distally snugly fitting stem in the tibial side, because it will sometimes prevent seating of the stem of the sleeve inside. And that is one of the causes where the sleeve can get loose because it's not seated well. So I tend to undersize my stem by one size or so in order to avoid this stem engagement distally, preventing the sleeve from seating inside the tibia. So these are the 3 points from my own experience in Indian patients.
Yeah, I agree. And I think, the last point I'd emphasize on the tibia, I try to go as long as I can and not go more than 14 millimeters. And the length gives me 3-point fixation, and the 14 millimeters allows me to pull the construct out of the sleeve in case I have to remove it later. If you go to a bigger stem, you can't pull it through the sleeve. So those are, if you can get away with a long 14 millimeter stem, that's ideal in most situations.
Great pearls, those. Great points. All right, so thank you, Amar. And let's go on to the stems now, especially offset stems. And Manoj will tell us thank you, Amar.
Anup, I apologize. I have to go to the operating room, but it's great seeing you all and hope to see you again very soon.
Yes, we understand. Thank you very much. Thank you once again.
Welcome. Take care.
You too.
Yeah, thanks, Anup.
Yes, Manoj, please.
Yeah. So now taking this away from a lot of cases where, we have a cost refrain and sleeves is not one thing we can use in each and every time. A couple of those cases can be managed with offset stems. So I will, in the next 10 minutes, answer only 2 things. Why to use an offset stem and how to use an offset stem. So in some patients, distal femur and proximal tibia and revision total arthroplasty may be shaped in such a way that the relationship between the articular surface and diaphysis imposes a stem pathway that does not allow the use of a standard straight stem. So in all these cases, the bailout is an offset stem. These are my disclosures. So when we use a stem in revision, what is the ideology? We don't want a subsidence. We don't want a collapse. We don't want an aseptic loosening, and we want the stem to do a load sharing, offload stress from the efficient bone to the diaphyseal area. In a lot of cases, our bone geometry does not allow the usage of straight stems. In anatomical variation, we have gentle valgus bow in the mid diaphyseal area, which leads to medial tibial overhang. Also, the tibial diaphysis many times is offset medial and anterior to the center of tibial plateau. So a stem aligned in the diaphysis would call a medial and an anterior overhang. So all these things are to be prevented. So if you go across in this case, matching with the diaphysis, you will find it on the proximal articular surface, you have an overhang. The only bailout is either you undersize your tibias, which is also not a good idea. So those are the cases where you use offset stem extensions. So you translate your tibia on the proximal surface, having a good diaphyseal support so that you have a fit in the diaphysis and a good proximal tibial coverage. So these offset stems, if not done like this in a straight way, would cause a medial overhang. So an optimal implant position is translating those and giving it a translation in the AP or the ML or both dimensions to have a snug fit across. If this is a sagittal plane and the normal geometry of the femur and the tibia, you want to put up a straight stem, you can go very well, and this is the right and the correct position. But in many situations, when you have excessive bowing, as we discussed through, you have an endosteal cortical breach or stem coming on the interosseal part, you have a flexion of your femoral component, and all these things are going to cause a lot of complications. So in all these cases, if you have a probability of an offset stem that allows you to centralize your diaphyseal support as well as put your femoral component on the right articular surface. So in the coronal plane, again, if there is the diaphyseal proximal articular mismatch, the only way to go across is use an offset stem, which will help you centralize and position your components. Also in cases where you have a distal femoral or proximal tibial osteotomy, that means you have a metaphyseal diaphyseal mismatch. This puts you into position to manage those things. You want to balance your flexor extension gaps and allows you to translate and position the components in a cortical breach. This is where it takes you. The points to understand in this is you want to have the closer the offset to the base plate, the fewer are the problems for the insertion and extraction. Also, another caveat is if you're using this kind of an offset stem with couplers and you use a very hybrid kind of a cementation with cement going into the metaphyseal areas, if at all you have to take it out, you're going to have a trouble sometime. Now, these offsets can be different ways, like in a TC3, you have a +2, -2, only AP dimensional offset, or in newer stems where you have a lot of translations possible. Now, these offset stems are available as modular as well as non-modular. Today, in majority of times, we use the modular orientations. You have a 360-degree arc of motion, and you have a choice to move from 2 to 4 to 5, 6, and a couple of systems, you have a choice up to 8 millimeters also. So now, talking of the indications for an offset stem, there are 3 indications. The one is an anatomical mismatch. Like we discussed with the metaphyseal diphyseal mismatch, like in a HTO or a distal femoral osteotomy or in a previous fracture or growth deficiency, if you use the center of the canal, you will be offset on the top. So this offset stem bypasses that. Or in cases where there is a malalignment. When uncemented press-fit stems are used, the alignment of component is dictated by the diphyseal bone. So this allows those kind of geometries to be bypassed. So if you have a picture where you have an asymmetry of the femur, the answer is again asymmetry or an offset stem. Third thing is gap balancing. We discussed multiple amount of times in a lot of pictures in a revision arthroplasty scenario, we get across a position where we have a very huge flexion gap. Now, in those cases, if you try to cut more of distal femur, you will have a proximalization of your joint line, which is not in ideal condition. So here, another condition is where you have a sort of bowing of the femur, which is very, very common in our conditions. You will again put a component in a direction, will have a wide flexion gap. So the way to move across is you use an offset stem, bring your component down, use a large size femoral component with the posterior augment. This way, you will achieve 2 things. Number 1, you will avoid any joint line elevation. Second, you will restore the posterior condylar offset, which is very optimal for good flexion and range of motion. So in the modular designs, you have this kind of offset couplers coming in different dimensions, 2, 4, 6. So also for our Indian scenarios, which I'll discuss, we have a pictures where we can't put in large offsets. So in those cases, male-to-male couplers are there. Our Indian bones have certain situations, and we will discuss about these. Number 1, for using these kind of couplers, many times when you have to ream 18 or 20 millimeters, you almost take off the anterior cortex, which is one of a concern in these cases. Smaller sized bones, the procavitatum or these kind of bowed femurs. So where you have a lot of problem putting in these kind of components. So in all these cases, offset stem is a good bailout. It centralizes your diaphyses, have a good endosteal diaphyseal support, and does not allow you to cheat or compromise on the articular surface. So to conclude, offset stems have a crucial role in surgeons' armamentarium for revision arthroplasty. 3 basic indications we have to keep in mind: anatomical mismatch, malalignment, gap balancing. It will allow you to retain your joint line and restore your posterior condylar offset. Also, Dr. Rajgopal will be unhappy, but majority of us feel that using a long stem is a better idea for load distribution than use short stubby stems, although people have different ideology on these things. And now talking of a small video snippet to show how to use these offset stems. So I'm going to use a lesion revision system, 55-year female, bilateral done 4 years back. She had a history of fall and aseptic loosening and subsidence of the implant. ESR, CRP and infection markers are normal. So the first thing, like in any case, is a safe and effective implant removal. You cut the interface between the metal and the bone cement, medial and the lateral side. Use these kind of offset punches and osteotomes to clear up the area, and offset punches take it out. The idea is to preserve the host bone and to have as much of natural bone preserved as much as possible. So the tibial component is looped and taken out. Use the burr to take off the soft tissues and to have a clear bone bed. I am reaming and I am proximal tibial resection. Just do a freshening of the tibial cut. Size your table component with these kind of sizes, like in this case, size 2, left side is the one. When you use a non-offset placement, you are almost out. So using different kinds of offset bushing, the first using 4 millimeter, which is too much for this patient. So we have an underhang in this case, using a 2 millimeter offset bushing, which allows you 360-degree movement of translation, anterior, posterior, medial, lateral. You have to see where you get the best containment on the proximal tibia and look at the marking. Like in this case, we have a marking coming at 9. You mark this through, use the tibial counter bore over your reamer. So while using offset stem, you have to take out the entire stuff and use this offset coupler counter bore in the proximal area. Then comes a stage where you have to do your offset trial assembly. So you have to see what was the marking there in your trial. You have to match it up, the tip base plate with the offset coupler, and then the kind of stem and the length of stem you have to use. Do not use so much of impaction. Align your tibia well. Now going back to the femur with the IM drilling, use different sizes of graters and the reamers to have an endosteal support. This is 16 into 160. So the sizes, the 2 is small and 3 is a good size for this patient. Now when we're using an offset, we have to see that we have to translate it in a direction that our anterior area is flush with the cortex. So this is where you see you're not proud, you're not notching, you're perfect on the AP as well as the ML dimensions. So the sizing is done. Your rotation is set with the transapicondylar axis. You take out your anterior and posterior cuts. The counter bore is done. And since you're planning to use an offset coupler, so we'll use a femoral offset coupler counter bore. In our very small bones, this is one of the caveat because it takes away a lot of bone anteriorly. Again, as the direction of the offset taken up, you will match up with the offset coupler, fix it up, and then use a trial stem. Now at this stage, you trial your components, you match your flexion gaps, and then come back and match your extension gaps. So in this particular case, we were wearing the box, and 11 mm PS trial insert was very good stability in flexion as well as extension. If you mark your rotation and then do a keel punch in the tibia. So the assembly in this case is base plate, coupler, and then the stem. You strike it with the mallet, and then you put these kind of screws to lock it in position. Always keep your trial along with that to see that you are putting your translation the same way as you had in a tibial and the femoral trial. When your originals are ready, you cement your femur and the tibia. So hybrid cementation, only the proximal surface is cemented. The remaining entire construct is uncemented. The endosteal support is with the fluted stem. So these stems are slit so as to decrease the rigidity, and they have these kind of splines for a better endosteal support. Once this is done, you put in your PS insert. You also have a choice of a varus valgus plus PS plus also. Restore the joint line, restore the offset. So this is how it looks like on post-op. Thank you so much for your attention, and I'm more than happy to answer any questions.
Yeah, great, Manoj. Some caveats on offset stems. And as you rightly said, we have to be very careful with 6 millimeter offset, especially when we are posteriorizing the femur, because it may blow off the anterior cortex. I think all these systems we are discussing, whether sleeves, offset stems, if you don't know the fine pearls, you may actually create some complication. That's what we need to prevent. Any points from the faculty? Any questions, comments? No, I don't see any. Okay. Yes. So probably only you and I use offset stems, probably.
I know. Yes, all our sleeve users, Anup.
Yes, yes, I can see that. Yes, but let's go to the man who uses the cones. And Dr. Rajgopal recently published midterm results in arthroplasty today. Dr. Rajgopal, I read that paper. So let's see your results, your techniques, why and how you use the cones, trabecular metal cones. All yours.
Thank you, Anup, and thank you, Subhranshu. Oops. Right. So I've been asked to speak on trabecular metal cones in revision total knee arthroplasty. And these are our disclosures, no bearing on this presentation. Clearly, the number of total knees, certainly in the US, has gone up as it has in this part of the world. And correspondingly, there is a huge revision burden. And one of the issues that most surgeons are facing is managing large bone defects, because managing these defects and methods of bone augmentation have become more crucial than they were in the past. I think the one thing that we need to look at when we're looking at bone defects is preoperative planning. And I'd like to start by emphasizing that instability, which is one of the hallmarks of bone loss, can be either because of bony defects or because of ligamentous incompetence. And there's a very subtle difference between the two, because if your instability is on account of ligamentous incompetence, then that is treated by increasing the constraint, as opposed to a bony defect that needs to be addressed by one of the many methods that have been described. You need to assess the extent and location of the bone loss, consider the need for augment, stems, and grafts, and most importantly, you need to have a full complement of implant and the constraint options, which should include the constraint condylar options and the hinge. Having said that, I think one of the issues that I would like to mention here is that the role of primary implants for revision procedures, while it gives good initial stability and outcomes, the Australian registry has actually reported on this, that there's a much higher incidence of failures when we use primary implants for revision procedures. So clearly, there are various methods of addressing bone defects, and I'm going to dwell only on the cones. And one of the issues that is in continuation with the theme of this past few talks is the role of the intramedullary stem extension when either constrained implants or large grafts are used. So let's talk about the trabecular metal cone. These are a very unique solution to large bone defects because they basically substitute for bone loss. They improve metaphyseal fixation, they correct the malalignment, restore the joint line, and permit the use of the shorter stem. And there seems to be some advantages of using this in terms of the infection resistance that it seems to purport. There is obviously a report that addresses the low risk of infection, making this a bacteriostatic implant available. I'll dwell on the shorter stem a little later. And again, the issue of the TM augment is to achieve stability of the construct in the proximal tibia and distal femur, while allowing the compressive forces to physiologically load the bone. It reinforces fundamentally the endosteal cavity and allows the stem to be inserted. And unlike the sleeve, which is dictated by the position of the intramedullary canal, when you have a cone, you can use offset stems, and that is the advantage. And you can position your components appropriately. So it allows for the entire assembly to provide appropriate coverage. The defects obviously need to be prepared for the augments. And earlier on, we used to have asymmetric augments for the femur and the stepped cones for the tibia. These have undergone recent modifications, and they're far more user-friendly and size compatible with much smaller bones. So typically, an example of a patient with massive bone loss caused secondary to osteolysis. This is an example of a trabecular metal cone. All the residual defect is packed with morcellated bone grafts. And I must emphasize that TM cones are always used in an uncemented mode. So this is a video. of a patient of rheumatoid arthritis. Her bilateral procedure was done 10 years ago. You can see gross instability. She had a varus instability. The points that were mentioned earlier, removal of the implant with almost no bone loss, I think this is very critical. We use the high-speed burr, particularly in patients who have large osteolysis. This removes the membrane. You then use a template, a broach, and these are the various sizes of the cones, both for the femur and the cement, femur and the tibia. And this allows us to insert the implant appropriately, and you can consider using the offset stem should the need arise. Important to understand that the flexion gap is a reflection of the femoral size, and a extension gap is a reflection of the femur distal position. So this is the femoral component going in. You impact it. This should actually be a friction fit, which means that once you have impacted this, there should be no way that there's any toggle. Any defects are filled with morcellated bone. So again, as I said, this is the endosteal surface is cemented, but the surface in contact with the bone, the cortical bone or the cancellous bone, is uncemented. And then you would put in your definitive implant or whatever description you chose to use. These are the post-operative X-rays of the same patient. Another patient who had a two-stage revision on account of infection. You can see massive bone loss. You can see there is a loss on the anteromedial side of the tibia. Again, a high-speed burr to remove any sclerotic bone. You size your tibial defect, use the appropriate size cone, and you can put in your trial implant through that, check your flexion and extension gaps, make sure you have a stable construct. This is the definitive cone going in. And again, to the point that Suri asked, when it comes to a TM cone, any exposed surface must be covered with a coating of cement because it evokes a phenomenal fibrotic reaction. And particularly in context of the hips, it has been known to integrate the sciatic nerve and with catastrophic complications. So when any bone, any part of the cone is left exposed, you want to cover it with a thin layer of cement. So some clinical examples: a patient with infection. Again, you see a morcellated graft, tubercular metal cone, and restoration of the joint line. You do not want to touch this with gauze because of the friction fit. The little particles of thread get attached to the cone. They're very difficult to remove. So it's always better to use it with these holders. In terms of the TM on the femoral size, you size it, measure it, size it, and do your trial, and then the final TM cone. When you look at the review of literature, the defect between the allografts and the porous metal cones, we have published quite extensively on the TM cones, and there's a very mixed bag, but most authors are of the opinion, and certainly our experience would sort of endorse that the TM cone gives a much better construct and seems to have some effect in reducing the infection rate. This is Mangani's very early articles, excellent short-term results, but longer follow-up needed at that point of time that they reported. 2000. These are all the very early articles that reported good outcomes, again, endorsing the fact that they needed longer-term results. And when we look at the longer-term results, we do see good osseointegration at 6.5 years. One of my fellows, Dr. Panda, and we wrote up this in the seminars in arthroplasty in 2018. Excellent follow-up at 10 years. And again, Jared's article in 2016 reporting good biomechanical and biological stability in revision total arthroplasties. Again, when you look at more recent articles, 2017, the use of TM cones has provided a effective treatment in terms of surgical efficiency and radiological osteointegration. So this is the article that we wrote up, where we used stacked TM cones, and this was reported in the Journal of Knee Surgery, where we used 2 cones. We have subsequently used 3 cones over a threaded long stem. We have this is our article more recently with large TM, large bone defects using tantalum cones in primary and revisions at a mean follow-up of 6.6 years. And this is our latest article, which was published in 2021 at 108 months, again with excellent osteointegration of the cones. Like you saw earlier, in our part of the world with severe defects, and even in primary situations, sometimes you need to use these cones. So these are some of the extended indications. This is a patient of mine. We did an uncemented total knee arthroplasty, Miller Galante 2 in 1991, an elderly patient. She had a road traffic accident, bilateral, completely shattered distal end femurs. And we've used a stacked cones. We used 2 cones, one on top of the other. And you can see excellent osteointegration and new bone formation 14 months after a surgery. These are just the intraoperative pictures. You can see massive bone loss, and this is really what we do. We have subsequently, for a similar patient, used 3 cones over a long stem with press fit osteointegration, and all of these patients have done extremely well. Some extreme indications: a very young patient with an aneurysmal bone cyst. The choice may have been to use a tumor prosthesis, but given his age and the possibility that if that got infected, he would have ended up with an amputation, we used a TM with a long stem. This patient is now almost about 12 years out to length, and you can see good new bone formation. In revision situations, an indigenous implant with a grossly dislocated patella, where we actually had to sculpt we had to cut the TM cone using a high-speed burr to accommodate for this indigenous plate, which we cut, and we restored this patient's joint line. Again, to Manoj's point, the use of offset stems, we do use a lot of offset stems. The only point I'd like to make to Manoj's talk on the short stem, that really was not a short stem. That was a press fit stem. Short stems typically are 25 to 50 millimeters. And if you are using those should be fully cemented. So using a press fit short stem is really possibly historical, should not be used in my opinion. So that is really the point that I would like to make. And this actually alludes to the fact that you can thread your stems any which way through the TM cones and use offset stems to get optimal alignment of your femoral and tibial component. So this has been our experience that we reported on in our most recent article, 108 months. And we reported on 62 patients. There was no loosening or migration and no revisions. So with that, I'd like to thank you for your attention. Be happy to take any questions if there are any. Thank you.
Thank you, Dr. Rajgopal. I think point clearly made that there is a difference between cones and sleeves, and cones actually work more like bone grafts, and once they integrate, they become load sharing, while sleeves actually fix and give metaphyseal fixation and share the load right at the outset. Is that correct? Is that the message?
I think so. Again, when we use metaphyseal sleeves, there are enough articles now, and there seems to be a growing body of surgeons who tend to use a sleeve without actually using a stem at all, purely relying on metaphyseal fixation. And some of the authors have actually reported this even for constraint options, and they have reported reasonably good short-term results at 36 months. Some at the longest follow-up that I was able to harness was about 44 months, and they seem to have good results. So there may be a place actually for using just the sleeve without the stems. But obviously, if you have large defects, large augments, then it makes sense to use some sort of a stem. We have gone, Anup, interestingly enough, we have gone almost exclusively now to using short, fully cemented stems. We use 50 millimeter stems, and we pressurize the cement. It makes revision procedures a whole lot easier. And again, we are preparing one of our articles to see. We've been doing this now for almost about 5 years, and we seem to have reasonably good results. There have been no loosening or migration of the components, no radiolucent lines. So it's possible that we may be able to get away from all the complications of using long stems, offset stems, and press fit stems.
Right. Yeah, I think Ritter has published a large series on short cemented stems, fully cemented, and there is definitely place for those. So, any questions from rest of the faculty? Any points to make, or we go on to the last?
Yeah, just
yes, sir, please.
Ashok, when you stack multiple cones, how do? You use a medullary guide to impact it?
So great question, Suri. So these are typically done for really comminuted distal and femur fractures. So what we do is we put the smallest cone into the intramedullary canal, and then we take our trial component and we stack the second cone on the trial component and thread the stem in contact with the proximal cone. And we push it in and we distalize, so the most we have used are 3 cones. The most proximal is the smallest, so that dovetails into the medullary canal of the available femur. And we can use progressively larger cones distally. And whatever comminuted bone there is, we actually use that as a graft and place it all around the construct. We sort of do some sort of an impaction grafting, if you will, and we mobilize these patients early. And it's remarkable that at about 4 weeks, 5 weeks, you start to see the sliver of bone osteointegration. And at 14 months, we now have almost about 14 or 15 of these patients with very severe combination. They are completely covered with new bone, which is really quite a gratifying situation.
Dr. Rajgopal, Dr. Nilen wants to ask whether you can attach soft tissues to TM cones, and if so, how do you do that?
So, Nilen, you don't actually have to attach it; attaches itself because it evokes such a profuse fibrotic reaction that any soft tissue is going to just attach itself to the cone. The only point I've done that a couple of times was with the patella. We had almost like a patelectomized patient. We had a very thin cortical rim, and we attached the TM button to this sliver of bone. And that was a mistake because at the time, I'm talking of almost about 9 or 10 years ago, that was touted as a very good option in patelectomized patients. And we actually did this. The patient, again, to your point, had such phenomenal fibrotic reaction. He had complete arthrofibrosis. The patient's knee would not bend, so we had to actually go back in, remove that button, which was a nightmare, I can tell you. Do a complete excision of all the fibrous tissue, and even at the end of that massive procedure, this patient ended up with something like about 65 or 70 degrees of flexion. So that taught us, and then subsequently there were enough reports, speaking to some of my colleagues, that the TM button on the patellar side was a disaster.
Yes.
Thank you.
All right. So maybe we can go on to the last talk by Rajkumar on a hinge, and then we take 2 cases by Mahesh and Nilen. Rajkumar?
Yes.
Please.
Can you see my screen?
Yes, we can.
Yeah. Good evening to all. Thanks, Anup and Dr. Mohanty, for inviting me to this excellent program about revision total knee replacement. My topic is on when to use a hinge, and almost all the points and the principles about revision total knee replacement has been covered by all the eminent speakers who talked before me. So I'll stick on to the exact topic, when to use a hinge. Just a quick recap. the first generation fixed hinge knee. The name here is a fixed hinge because it is always fixed, highly constrained, and because of this constraint, it transferred high stresses. So it is not available now, this first generation. Second generation, some amount of axial varus and valgus movement was there, but because of the unacceptable high failure rate, nowadays this is not used at all. The most preferred, the third generation rotating hinge knee, which we use regularly. These are the rotating hinge knees, which allows almost 25 to 30 degrees of axial rotation on the tibial plateau. So which reduces the stress transfer to the bone implant cement. So this is very, very important point because this prevents the complications and the failures in using a rotating in a hinge knee. So the third generation hinge knee, what are the other modifications happen? The modularity, the prosthetic modularity and the super alloys which has been used. The anterior femoral groove has been deepened. The biggest problem in a hinge knee is the maltracking of the patella, particularly after 60 degrees of flexion. So to avoid that, they have deepened that. Broad polished tibial components and congruent poly, it increases the conformity. So there is a good load sharing transferred from the condyles to the insert rather than to the hinge mechanism, which is the cause for the failure. Multiple sizing for better metaphyseal fit and fill, which helps in the revision scenario. Long stem extension and distal augments, obviously that is really helps to balance the flexion extension in revision total knee replacement. So with this modifications, the rotating hinge knee, the third generation rotating hinge knee gives a very good results. And coming to the indications, when to use a hinge knee, definitely there is a big dilemma. Nowadays it has been loosely used, anything use a hinge knee. It should not be the case. So what are the exact indications? Broadly to classify, everybody will know that in a revision total knee replacement, hinge knee is used. But in nowadays, with the third generation rotating hinge knee, the complex primary total knee replacement also has got a hinge knee has got a role in this situation. When it is that any primary total knee that requires increased implant constraint at the time of index surgical procedure to achieve a stable knee. So whenever there is compromised stability, then you have to think about a hinge knee even in a complex primary total knee. What are the absolute indications? As it was mentioned in the previous talks, femoral or tibial tumor resections that sacrifice the origin or insertion of the collateral ligament. So whenever there is a collateral ligament origin is compromised in a tumor resection, you need to use a hinge knee. A gross ligamentous incompetence, particularly in a medial collateral ligament, and then the severe bone loss. Why it happens? Osteolysis due to sepsis or component removal. So all these things puts femur or tibia into a very big bone loss situation where you have to use a hinge. So these are the three most absolute indications. The ligament incompetence and the bone loss goes hand in hand, and you have to take a good judgment at the time of the surgery when to use that. So what are the relative indications? These are the indications which is used in the complex primary situations. Whenever there is a severe valgus or a varus deformity with flexion contracture, where you need to release so much, and finally you have to release the collaterals also, then you need to use a highly constrained like a hinge knee. And particular cases like neuromuscular diseases, polio and Charcot's arthropathy are definitely an indication for hinge knee. Severe recurvatum, it might look little simple. By distalizing the femoral component, you might be able to achieve. But sometimes there are situations where you cannot get away with the primary implant, even with the distal augment, where you need to use a hinge knee. So these are the relative indications to use a rotating hinge knee. So what are the principles of reconstruction? Already Krishnakiran covered excellently about the principles of revision surgery. The same thing applies to the rotating hinge also. We should not take it for granted, thinking that a rotating hinge will take care of everything and just go ahead and remove everything and put a hinge knee. Not at all. You have to rebuild the tibial platform, re-establish the flexion gap, and reconstitute the extension gap. Unless you do that, a clinical better outcome will not be achieved. So always stick on to these three principles. Very, very important. So let me take you through the case examples, which will cover the indications one by one. So hinge knee in a bone loss situation. When is that bone loss? Bone loss of ARI type 3, that is the metaphyseal compromise. Femur F3, tibia T3. When this is there, definitely you have to bypass the metaphysis to get a good fixation. That means your collaterals also are damaged. So you have to use a system where you augment the bone defect by sleeves and cones, as it was discussed, and also you have to use a rotating hinge knee. So this is very, very important. Whenever there is a big bone loss, you have to consider a hinge knee. So complete, it is actually both together, the bone defect and the soft tissue. You have to decide. So starting from a less constraint to the hinged system, you have various stages. So based on the soft tissue compromise, that is a ligament incompetence, and the bone loss, at what level it is. So whenever there is a F3 or T3, hinge system is a must. So this is a case example. If you look at this patient, already underwent a bilateral revision total knee replacement, and look at the massive bone loss happened both sides. So here in this situation, I managed with a regular constraint system with a sleeves to augment the bone loss on the left side. But however, right side, because of the massive metaphyseal bone loss and also compromised ligament collateral attachments, I had to use a rotating hinge knee. A 51-year-old male, deformity in the left knee, but he did not have any pain at all. He was walking with the limp, and see the amount of destruction the bone in the knee joint and the alignment, severe varus deformity. But once I opened it, it was so much of synovial hypertrophy, loose bodies, and the whole knee is totally different when compared to a regular normal knee. So looking like some doubtful neuropathic joint, and also bone loss. See the amount of bone loss here. And in spite of taking a very thin tibial cut, there was a big flexion gap. So here the problem is severe bone loss, gross instability, and no pain. So obviously I did a rotating hinge knee, and to augment to get away with the bone loss, I had to use sleeves on both sides. And this is a 5 years follow-up with the rotating hinge knee system. So here the message is rotating hinge knee is indicated in severe bone loss and gross instability. So what is the next is the severe valgus knee with femoral fracture non-union. 58-year-old man, windswept deformity, rheumatoid on steroids, neglected supracondylar fracture, and also diabetic. See the knee joint, the femur fracture, we don't know whether it is fully united or not, bone loss and valgus deformity. And the patient has got the alignment is valgus and also hyperextension and fracture in the supracondylar region. All these things, and perioperatively see the bone loss in the tibia. It is almost extending into the metaphysis, and definitely you cannot get away with a regular release, soft tissue release, and you have to compromise with the collateral. So in this scenario, I used a rotating hinge knee. The sleeves were used to reconstruct the joint and achieve the joint line, and then a hinged system was used. And this is how the post-operative X-ray looks. So this is a situation where a fracture is associated with bone loss, with insufficiency, hyperextension. So the message here is rotating hinge knee is indicated in severe valgus knee with gross hyperextension and also fractures around the knee joint, whether it is in the tibial side or in the femoral side. Next is the neuropathic joint. 49-year-old male, tall and obese. His deformity is progressing in the left knee, and he also has got history of frequent fall while walking, known diabetic, hypertensive, ischemic heart disease, and chronic kidney disease. Looking at the X-ray, the lateral femoral condyle is eroded. Look at the patella, it is subluxed already, valgus alignment. So he has got grade 3 instability, valgus knee, and hyperextension. The combination is not good, and the MRI showed neuropathic arthropathy of the lateral tibial femoral articulation with complex degenerative meniscal tear with a lot of osteophytes, extensive synovitis. So this is a classic case of neuropathic joint. So look at this, the swelling around the knee and in the leg, and also the femoral condyle is eroded. Even here, because of the neuropathic joint and the compromised ligament instability, I used a hinge knee. On the tibial side, no sleeves were used because no bone loss, but on the femoral side, because of the hinge, femoral sleeve was used, and this is the post-operative X-ray. Same patient, 1 year later, came to me again with a spontaneous fracture of the ankle. So this was again a Charcot's arthropathy of the ankle joint for which fusion was done. So this is, the message here is very, very clear. Rotating hinge knee should be used in a Charcot's arthropathy. So Then coming to the gross ligament instability post-total knee. We see these cases regularly in our outpatient clinic. 63-year-old female underwent a total knee replacement. And in the 5th month, the patient had this problem with pain and difficulty in walking. The surgeon braced the patient and sent her back. 9 months later, patient came to me with this situation. Completely subluxed, gross instability. And this patient was taken, and when you open the joint, the medial side, tibial side was almost no attachment was there. The MCL was attenuated, and after the implant removal, I had to use a hinge knee because of the compromised ligament insufficiency. So here a rotating hinge platform, 2 years follow-up, and look at the patella, which is tracking very nicely because of the modern 3rd generation rotating hinge knee. So one more example, gross medial collateral ligament insufficiency. These kinds of cases, even if you try to get away with a regular constrained knee, the failure chances are very, very high. So this case, these kind of ligament insufficiency, very gross instability, better with the 3rd generation rotating hinge knee, which gives a very stable joint and good outcome. So the message here is rotating hinge knee in gross ligamentous incompetence. So the next is the hinge knee in poliomyelitis. So in polio, the problems are poor bone quality, hyperextension, and gross ligament joint laxity, valgus alignment, and patella vaga. These are the situations we routinely face in a hinge polio cases. So this is definitely an indication for a hinged rotating hinge knee. So what level of concern in post polio we should do in a total knee replacement? If the quadriceps power is good, that is, if the extension is reasonably better and no severe valgus or hyperextension, then you can think about regular total knee replacement. But still, we want that there are chances of failure. But if the quadriceps power is weak, gross valgus and hyperextension, then definitely you have to think about, or you have to use a rotating hinge total knee replacement. One more example of a post-polio case. Look at the destruction, painful knee, patient while walking has got hyperextension and valgus deformity. This is the case where severe hyperextension is there, and a good result is achieved with a rotating hinge. Because of the osteoporosis, a sleeve was used on both sides. So the message here is rotating hinge knee is indicated in post-polio limb if the quadriceps is weak and gross hyperextension. You cannot get away with the regular implant even if you try to dislice the femur. So hinge knee in a gap mismatch, flexural instability or a gap mismatch happens, but majority of the times you can get away with the regular revision implants. But sometimes it requires a hinged implants if there is a major instability. 72-year-old female, obese, diabetic, 3 weeks post-total knee. Look at this case. The patient, it's an all-poly implant, but the surgeon did a debridement and washout for some wound dehiscence. And immediately after that, you can see that amount of flexion instability. 10 months later, patient presented to me with this kind of situation. Everything dislocated. And this is a clinical scenario. Patient has bed sore with discharging sinus. So here, once you opened, I found that there was a huge flexion gap, which was too loose, and a tight extension gap. And also apart from that, the posteromedial aspect, there was gross opening, there was no soft tissue stability there. The MCL was very much stretched and attenuated. So this is a case where there is a gross flexion mismatch, gap mismatch, and also some insufficiency. So the message here is rotating hinge knee in gross gap mismatch and a major instability, you have to use a rotating hinge knee. So hinge knee in a post-septic revision, it was discussed before. All the speakers mentioned about the bone loss in these kind of situations. Yes, in a example of 57-year-old female rheumatoid septic loosening post-TKR, always in these kind of situations, particularly in this patient, twice debridement. See the amount of bone loss there because of the infection, and then the cement spacer, everything erodes the bone. So lands up in a massive bone loss. So in this case, underwent a revision totally because of the bone loss, but no sleeves were used. A simple rotating 3rd generation rotating hinge knee was used. So message again here is rotating hinge knee is indicated in osteolysis and bone loss happening due to post sepsis, because even the ligaments, the collaterals are compromised in this kind of hinged septic situation because of the radical debridement we do. So the next is the hinge knee in a periprosthetic fracture. Here the patient had a trivial injury 7 months back. He neglected it. Because of that severe pain, loose component. So here the problem is ligament insufficiency, neglected fracture, and loose components. All bad combination here. Once I opened, the femoral components were loose, and that see the femoral condyle, medial femoral condyle, almost 3/4 of the condyle is lost, and a huge fracture lying separated. The collaterals are insufficient here. So this is the situation, no femoral condyle at all in the medial side. So this is a classic case where the metaphyseal bone loss is bypassed with a sleeve, and then a hinge system is used because of the ligament insufficiency. So the message here is rotating hinge knee in a periprosthetic fracture, which is not amenable for fixation and bone loss, and because of the bone loss. So whenever you are not able to fix the periprosthetic fracture, then you have to think about using a rotating hinge knee. One more example, 70-year-old female, but the situation here is little different. What is that? Grossly osteoporotic and severely comminuted, 6 years post TKR. Look at that. When you open it, your entire bone is gone. We don't know where it is because completely it is crumbled. So no way you can fix it, or you can no way do a regular hinged system. So what is the solution here? A limb preservation system is the only way to tackle this problem. So why tumor process was used in this case? Because of the severe bone loss, no ligaments, and no condylar bone to implant the femoral component of a regular hinge knee. So we have to be very careful. Even a sleeve or a cone cannot be used in this situation because the entire metaphysis is gone. So the limb preservation system or a tumor process is the only system. So rotating hinge tumor processes is indicated in a periprosthetic fracture with severe bone loss, which is not amenable for a hinged condyle fixation. So the last case example, hinged in a tumor around the knee, 37-year-old male, recurrent GCT, which is very aggressive of the lower end of the femur, twice operated, soft tissue extension, huge mass. This was the the tumor excised. After that, you can see the big bone loss. The entire condyle metaphysis, everything is removed. So very obvious indication with the tumor processes. Again, this is a hinged knee. So rotating hinge knee, tibial side, no sleeves or anything was used because no bone loss. Only the femoral side, the tumor processes is used with a hinged knee. So message, rotating hinged tumor processes in tumors that sacrifice the origin or insertion of the collaterals, then a hinged knee is indicated. Just 2 recently published papers. It's a review article, level 1 paper. Rotating hinge processes has favorable outcomes for patients, but it is the infection which is a risk factor. Again, one more article, JOA published. Again, good outcomes because of the modern rotating hinge system is very good, but you have to be very careful with infection again. So to conclude, 3rd generation rotating hinge knee is a good system, but in complex primary, it is the specific indication and the ligament instability which should be the deciding factor. But however, in a revision scenario, a hinged knee should be used only when less constraining processes are unlikely to provide adequate stability. That is particularly in a bone loss situation like F3 or T3 or both combined together exist. So thank you for the opportunity.
Thank you, Rajkumar. That was great. Especially, I like the message that came in last of every case, really highlighting the important message of the case. Thank you very much for that. Really,
thank you.
Review on case-based, really on hinges. So if we have any questions, we can take them, or we can go on to the 2 cases because I think we're really late on schedule.
One quick question, Anup, for Rajkumar is, has he noticed when he uses an SROM noise kind of a hinge, has he noticed that the patients sometimes do control of instability for the first year or so?
I didn't get you, Magesh. What is that? Instability about what? SROM noise?
SROM noise hinge, because of a rotating component, unless the patient has extremely good quadriceps strength, they notice that the knee remains a little bit unstable and gives way on them.
Correct.
Have you noticed that in your patient?
Rotational instability. Rotational instability. I agree with you. I've seen them. Yeah.
So that is one point I said. You have to stick on to the principles, because if your rotation is problematic, the patella also tends to subluxate laterally, and there is a big instability happens. And also we all think that flexion extension gap is not that important, but even in a rotating hinge knee, you have a jump this thing of only 3 centimeters to 4 centimeters of that hinge, that screw which goes inside. So you have to be very careful in getting your principles correct. So you have, as we say in the revision, we have to keep the insert size as low as possible. Don't elevate the joint line. So I don't think specifically this problem I have not noticed in.
I think it's mainly the subjective instability that I was talking about, rather than clinical instability that you can.
I've not noticed any that kind.
So Mahesh, I agree with you. I have noted. And Rajkumar also, I think for the audience, those who are listening, I think hinges is not really the savior for all polio knees. You need at least a cord power of 3. If you have a cord power of 2 or less and you do a hinge, even that may fail, especially a polio.
No, Anup, can I just add one quick point on that?
Yeah.
Yeah, the problem is, I'm not telling that all polio needs a hinge, but only if it is a gross hyperextension. The problem is, in a polio knee, if you do a regular knee, then you have to get the knee in little flexion to prevent a post-operative stretching. But a patient with a hyperextension in polio is used to walking with a hyperextension knee. If you correct that hyperextension with a regular implant, he cannot have that walk again. But in a hinged knee, where you can allow the knee in little hyperextension, 3 to 2 degrees of hyperextension you can allow. So you have to be very careful if you are doing a hyperextension, polio with hyperextension, because post-operatively it will stretch.
Correct.
Can I make a point?
I think I will differ on that. I think the only contraindication for a hinge is hyperextension. You should never. So if you leave a hinge in hyperextension, it is bound to fail. So I agree with Raj that you may have to do it in polio sometimes, but you need to brace them for life.
No, but
you cannot
not, I'm talking only about polio, Kiran. That hyperextension thing is only about this.
No, but any hyperextension is Thorsten Gerke says
the implant allows.
hyperextension is poison for a hinge knee. So
I think, can I make a comment?
I think hyperextension is really detrimental for any knee. Yes, sir. Last comments on the yes.
Yeah, so I totally agree. RHK is not the panacea for everything. We have seen the central screw actually dislocating, particularly with hyperextension, and that is one indication where you really want to be very, very careful if you're choosing a rotating hinge, because the central pivotal pin, we've actually revised this on at least 3 occasions where the central pivotal pin actually just popped out. So I think you need to be extremely cautious. And the other point is you need to factor in the status of the foot and the heel, particularly in these hyperextension situations.
Right. Absolutely agreed. You got to look at the whole limb. And if it's really hyperextending with great cord power 2, maybe you could just leave them alone maybe.
The hyperextension is probably an indication for a fixed hinge. You should not do a rotating hinge in a hyperextension. You can put a fixed hinge in and brace them for life. That is what you have to do.
Right. Okay, Mahesh, we can go on to your case. I know it's late, it's 9 p.m. But anyway.
Yeah, thanks, guys. I think we're already extremely late. Thank you, IA and Anup and Dr. Mohanty. This is a lady who is 1 year down the line following a bilateral knee replacement done, obviously elsewhere. I wouldn't do it this way. And she's got pain on in both her knee joints. And we've done the complete workup. There's no history of fall. She's 70-year-old. The CRP, ASR, and the aspiration have turned out to be negative for infection. So these are primarily aseptic loosening at 1 year down the line following surgery. And these are the lateral views. So maybe, how do you want to do it, Anup? We want to probably go through quickly. I can't hear you.
I think we should have a discussion so that.
Sorry?
You can complete the presentation.
Shall I complete the presentation rather than waiting?
Yes, please complete and then we'll
So I think there were several problems here. As you can see on the AP radiograph, there is tibial loosening on the right side. On the left side, you got a fracture of the medial femoral condyle as well as tibial loosening. On the lateral side, you can see an oversized or a loose femoral component on the left side. And on the again right side, you can see extended femoral component, and the tibial component is loose as well. See a scanogram of this patient. You can see valgus malalignment on the right side and a varus malalignment on the left side, probably due to fracture of the medial femoral condyle. So Obviously, we did one at a time. So we did the left side first. And here, because there is a fractured medial condyle, there is probably you need to keep a hinge standby as well, depending on what you find intraoperatively. But I think we were able to get away with a wedge on the tibial side. We reconstructed the medial femoral condyle with some bone graft. She did well. And then after a month or 6 weeks, we revised the right side as well, which was painful and loose mainly on the femoral side. And because the right knee was in valgus malalignment, we adjusted the tibial cut using a hemi wedge to correct that slope on the tibia. And you can start seeing that at the end of 1 year, the medial femoral condyle has healed well. You can see a slight suspicious radiolucency here. My bad, probably we should have drilled a little bit more for that cement integration into the sclerotic bone as well. But this is now 10 years down the line. I did this case in 2010, and at 10 years, I think she's done brilliantly with good incorporation of that medial femoral condyle fracture, decent alignment on both sides. I always use a cementing technique, which is a hybrid cementing technique. So the rod is not too tight. So we use cement in the metaphyseal region and onto the base plate as well on both the tibia and the femoral side, so that we can get a decent long-term result. So comments, please. Yeah. We wanted to keep it short. We are already late now.
Yeah, I know. Maybe we can take some questions, comments. Anybody? So instability, malalignment go together, Mahesh, don't they? I mean,
yeah,
malaligned is also unstable in many ways. Yeah.
Yeah. So I think the principle that I would like to stress upon here is to correct the alignment, obviously to get good fixation, decent fixation, at least in 2 zones. And that will give you a good long-term result with balanced knee functioning very well. You don't have to always use the most constrained implant that is available in your hands to get away with instability or a fractured condylar region.
As I see, this is a Zimmer system with offset. Offset stems, which gives you offset about 4 millimeters both on the femur and tibia. Give you the advantage of adjusting your implant positioning as we were talking. A great system, this and the others. Yeah.
I prefer to use the offset because it does really get the alignment of the component onto the metaphyseal area very much better than a standard straight stem.
Correct, correct. And this is a mid-level constraint. This is CCK.
The VVC constraint, so varus valgus constraint, so LCCK design.
Very good long-term results, 15 years.
Just the one question I didn't ask Rajkumar was, I think now in the long term, the results of an RHK are probably slightly better than a LCCK knee, because there is too much of constraint in LCCK as compared to RHK. So the stresses on the interfaces when you use when you use a LCCK are much higher, on the contrary to the hinge, because the hinge has a rotating platform. So I think the stresses onto the bone implant interfaces are less in a hinge. So a hinge is not completely to be given away.
Of course.
Correct,
indications of, but here probably the ligaments were intact and the patient was slightly younger. So probably you chose this, which was the right choice. Okay, so if there are no other questions, we can go to the last case by Nilen. Nilen, sorry to put you at last because you were at disadvantage because you are a friend. So I took that liberty of putting you last. Sorry for that. Okay, please.
Thanks, Anu. Anytime. I have actually enjoyed myself quite a lot. There have been brilliant cases. Can you all see my slides?
Yes, yes, we can.
So the last few hours have gone really well. So thank you. And thank you, Dr. Mohanty, also. So in the year 2011, this 65-year-old lady without any comorbidities came to me. She had a history of right total knee in 2003, was never thrilled with surgery, was managing, and no problem with other knees or joints. And this was 8 years from the time of surgery. And when you looked at her 5-year X-ray, I don't know why this is advancing a little bit too quickly. So fiber X-ray is showing this. So the issues obviously is actually just give me a minute. I'll just stop sharing and see whether I can change this. Huh? Just give me a minute.
Wow. So while you do that, Nilen, maybe I can summarize what we have discussed. That there are multiple.
Sure.
Are you ready?
Oh, I think it is. Yeah. Okay. Let's see. So the issues are whether there was any infection. There is a huge defect of osteolysis, and obviously there is the issue of balancing. So what I did was I did a subvastus approach. I took samples for culture. The knee did not look infected. Post was completely worn out. The medial poly also was worn out. The tibia was loose. There were huge femoral and tibial defects. And here you can see the subvastus exposure that I had taken. Carefully, I took out the implant at the implant cement interface, unhurried and unforced. Posterior condyles were separated before the implant was removed. And this is after the femur was thoroughly debrided. And if you see the loose tibia, and this is after the tibial component was removed. And if you carefully see here, it was like an uncontained defect. And there was a fracture of the proximal tibia also. So in the year 2011, I chose to reconstruct this with a wire mesh, as you can see here. I fixed it with screws and bone graft. The femur was prepared to receive a TC3 femur with sleeves and rod, adequately sized. Posterior augments adequately distalized also, and defect was filled with cement and sleeves. The implantation was separate, tibial side first. These were the revision implants. And here you can see the implants inside and the tracking which was possible through the subvastus approach. And as you know, all this was done without a tourniquet. And these are the post-operative radiographs. And this is the follow-up, and she has remained well. So my take-home message is that intervene early if radiographs are not looking right. Although Suri took a brilliant lecture, subvastus was not mentioned, and I believe that subvastus can be done for revisions as well. The hybrid system of metaphyseal fill can be done, but you have to meticulously follow the principles of revisions which all the eminent speakers have enumerated. I thank you for your attention.
Thank you, Nilen. And undoubtedly, you use subvastus for everything. And I've seen you live using subvastus for revision in one of the courses, and that was quite brilliant. I wouldn't have the guts to do it. But anyways, any questions, any comments from rest of the faculty? Anything to add on? Nilen, can you go on the post-op X-ray a couple of slides back and maybe, yeah. So, any comments on that? Or
brilliant.
See, although Amar mentioned that the sleeves can be used even though the defect is uncontained, some people say that putting an uncontained sleeve may not be that great an idea. So I have reconstructed the proximal tibia with a wire mesh, put a lot of allograft inside. I think you can see the wire mesh and the graft inside, and then put the sleeve in.
Dr. Nilen,
yes, Rajkumar, go ahead.
No, the sleeves principle, what Dr. Amar was mentioning is in their, the bone quality in their place is totally different when compared to our bone quality and the size. Majority of the time, we don't cross the sleeve, first sleeve size at all in India. And very not that commonly we use an uncemented sleeve that is like the second size or the third size. So in our scenario, most of the time it is the cemented sleeves we use. So there is no question of leaving it this thing, but the entire bone loss, whatever the bone loss is there, we can rely on the sleeve, and we need not do any augmentation or anything or screw or anything, just to fill it with the cement.
See, on the femoral side, Rajkumar is, and Nilan also, is if you have put a sleeve and you put your femoral component and you completely, because we have a very small size bones, we push the first size cemented sleeve and you put the femur, you will still find a gap between the femoral component and the parent bone. Would you not fill that with the augment?
No, that's what, if there is a gap big enough to put an augment, definitely it is better to put an augment. Otherwise, you can cement is enough. But actually, the sleeve principle, if your sleeve fixation is good, you need not worry. That is what the principles of the sleeve.
And if you are putting a larger sleeve where you can, basically allow one or two threads of the sleeve, steps of the sleeve remain, free in air. Doesn't matter, so it can remain free in the air, and that's okay. Yeah.
See, what I would say is that
point, again, I think I made it earlier, but I want to make it again. Anup, can I do that?
Yes.
Yeah, the femur and tibia are completely different. The tibia is a stem and sleeve construct. It's like SROM. So even if your proximal tibia is unsupported and your sleeve is axially and rotationally stable, you do not need any reconstruction or cement there. Femoral side is completely different. If you're using a TC3 type of femur, you have to put in a bolt, either a neutral or a 2 millimeter anteriorizing or posteriorizing bolt to connect it to the taper, which gets locked into the sleeve. So you have a very weak, potentially very weak junction there. All the stress will be on that bolt and the trunnion and the sleeve interface, because it's not a stem in sleeve construct. So it is mandatory that if you use a TC3, you cannot leave the femoral component hanging in the air. So if you require a centimeter of augment distally and posterior augment to optimize the femoral host bone contact and cement it in that position, you will have to do it. The SROM noils is slightly more forgiving because there is no modularity with a bolt going through the TC3 box-like situation. But even in that situation, it is not a good idea to leave an unsupported femoral component when we are using a femoral sleeve. So that is the difference between femur and tibia.
On femur, you have the choice of using augments and getting good host bone contacts.
I will go a step further. I'll say it's mandatory to use augments whenever we are using a femur.
Right. I agree with you completely. That's right. So, okay, maybe it's time to sum up. I know we are running late. So maybe the first thing is, of course, to get the soft tissue exposure right and get a clean exposure, maybe with a rectus snip or a tibial tubercle osteotomy.
Nilan has to stop sharing the screen.
Yeah.
If we are planning a tibial tubercle osteotomy, then we have to do it straight away and not do a rectus snip and then do a TTO. So if you're planning a TTO, do a TTO right away and not after a snip. Then go through all the soft tissue principles that Krishna talked about. Most important is to balance the gaps. And how you fix, whether it's sleeves, cones, or stems, is your choice. But I think all of us would like to say that get well versed with one system. Don't keep jumping on from one system to another just because company people say it. I think get really into the depth of one system and use it and become good at it. I think all faculty would agree on that.
Correct. Absolutely.
Very much.
All right. So is Dr. Mohanty still around? Dr. Mohanty?
No. Actually, Dr. Mohanty sir is in Bhubaneswar and there's a problem with his internet actually. So,
okay.
Just sir, if you can give some concluding remarks, I'll just make one announcement at the end and then we can conclude the meeting.
So I think I like the whole exercise. Maybe you can.
So actually, I just got a call from Dr. Mohanty. He just told me to thank all the foreign as well as the Indian speakers today for fantastic delivery of lectures. And just to make a small announcement that the next webinar of Indian Arthroplasty, the IA webinar series number 16, is going to be on cemented total lip arthroplasty and back to the future will be and the convener is going to be Dr. Samarjit Patnaik, senior orthopedic surgeon and arthroplasty surgeon at Apollo Hospital, Bhubaneswar. So that will happen on the 18th of May, which is the third Tuesday in the month of May.
Great. Thank you.
Lovely. Well done, Anup.
Time. Thank you very much.
I
Excellent.
just
Really
stopped
enjoyed.
the screening now
Night.
on YouTube.
Thank you very much.